Hi, everyone. So I'm Christina, and this is actually a re-recording of the live session that I did yesterday. And just a word of advice for the future. When you guys are recording WebEx meetings, make sure your updates are shut off on your Mac because it takes like 2 hours for it to like download to the computer off of WebEx. But if your computer decides to randomly update, you lose it, which is great. So, anyway, my little spiel. Christina, I'm in the DO PhD program at Rowan. I started at Rowan PBL program 2019, finished 2 years, took boards, and now I'm in the PhD portion. I'm actually coming back to join your guys' class when you're third years, so we'll be classmates. But in the meantime, I usually help out, I facilitate, I tutor a lot. So I might facilitate for you guys in the future. I just like sub when I'm needed. But anyway, yeah, so we're going to do cardiorenal anatomy and embryo. And kind of how I structured this was I put in path whenever I thought that there was like an instance to throw in path. I know first year path isn't really as important as like second year, but it's still like any time that they can tie it in with anatomy and embryo, you should kind of study that. But I put it in here everywhere that I thought would warrant it. I think that's it. I also, since again, no one's on this session right now, obviously, I tried to like kind of, I'm gonna like talk about things that I got questions yesterday. I threw them in here just so we can talk about it. I also put in some congenital cardio defects in here and I skipped them yesterday. But since like I'm not gonna feel bad going over time because you guys can play this at like 1.5 speed if you want, I'm probably gonna do it now just because I have the extra time. So there are some changes. So if you did not go to the live session, but you know people that did go to the live session, just tell them there's some extra info in this posted like recording and in this PowerPoint than what they probably have. Okay, so kind of how I structured it again, cardio anatomy and embryo, tying in the path, going over just some high yield stuff, doing mediastinal anatomy very briefly, and then the finishing off with renal anatomy and embryo, which does not take nearly as long. So before we start, so there's cardiac anatomy, gross anatomy, and microanatomy, so some histo. Before we start, I wanted to just give you my little spiel on like this block, because this is like your first block where it's two body systems in one, right? So it just seems like there's just a lot of information. Just focus on physio. Really, really, really focus on physio. Path is really going to come in anywhere that physio goes wrong or that they can make like a physio connection, or with something like anatomy and embryo where it goes wrong and they can make a connection to like the path. So I personally use Costanzo and Clabunde. Clabunde has a website. It's called CV Physiology. And if you're ever doing anything with cardio and you get confused with something or like you need to like kind of be like, I need to hear this another way, type it into Google and then literally just do Google and then CV Physiology. And hopefully that will, and hopefully that will clear it up for you. It's just like they're really quick kind of summaries of like topics, and I think they really help. Anyway, what I think you should be focusing on for first year is like again kind of similar to Palm, like equations, like action potential ions, so like very physio heavy, like biochemy stuff that people don't usually like. Electrophys, your G protein coupled receptors make a comeback this block as well. Lots of graph interpretation, so like things like Wigger's diagram, pressure volume loops, autoregulation, Frank Starling, nodal and contractile cell action potentials, all those graphs, you need to know all of them. Baroreceptors and shock are also important. Murmurs, super important. For your H&P section, I'm pretty sure like all of the H&P questions are murmur questions, so that's kind of how they ask that. Congenital cardio defects, which I'm going to actually talk about today, which I didn't do in the live session. And evolution of an MI, I had bolded, like I highlighted this because I added it to this PowerPoint. I was literally thinking about it after the session. I'm like, that's some good histology. Like they can ask about that. So I have those slides in here too. We're going to go over those. And then just as a general reminder, don't neglect vascular portion of this block. It is cardiovascular and renal. So just don't forget like the vascular system's fair game. All right. So basic cardiac anatomy, there are 3 layers to the heart. There's the endocardium, myocardium, and pericardium. There are 4 chambers of the heart, the right atrium, right ventricle, left atrium, left ventricle, and then the right atrium to the right ventricle goes through the tricuspid valve, right ventricle to left atrium, well, to the lungs, to the left atrium, goes through the pulmonary artery, and then through the mitral valve to the, to the left atrium, then through the mitral valve to the left ventricle, and then out to the aorta. And just at a basic, you need to understand that the thickness of the left ventricle is much, much, much more thick than the right ventricle. And that's like a gross anatomy thing. If they just show you a portion of the heart, they're like, what is this? You can be like, all right, that is very thick. That's probably the left ventricle, or just the left side of the heart in general. Here's kind of just like a rough overview. If you were to like take the heart out of the chest and just like coronally section it, this is how it would look. And just right away, I really want you to notice the thickness of the heart. So the thickness on the left side is a lot thicker than the thickness on the right side. And again, that's just because of the amount of pressure that it needs to sustain. So remember, from pulm block, the right system, the pulmonary vascular system is very, very, very low pressure. It's a very low pressure system. We don't want to kind of injure the lungs shooting blood in there as fast as possible. The left side of the heart, or the systemic vascular system, is a very, very, very high pressure system. Again, the arteries need to give blood to all the organs in the entire body. So the left heart needs to pump very, very hard to make sure that it's getting throughout everywhere in the body. Otherwise, like your legs won't get blood or your arms won't get blood. But just as a basic, this is what it looks like. And if we were to track blood flow, blood comes in from the inferior and superior vena cavas. It goes into the right atrium, through the tricuspid valve into the right ventricle, through the pulmonary valve into the pulmonary trunk, out to the lungs. Then back through the lungs, through the pulmonary veins, into the left atrium, through the mitral valve into the left ventricle, and then out through the aorta to the rest of the body. Something I want to point out with this picture, though, is there are, and I have this on like a future slide, but there are 4 pulmonary veins. There's 2 from the right side and then 2 from the left side. That's like just a random anatomy fact that tends to come up every now and then. All of the pulmonary veins drain into the left atrium. So I know like the right pulmonary veins over here kind of look like they're like, I don't even know, they're just there, but all 4 of them drain into the left atrium. So there should be like 4 little holes like this for those pulmonary veins. Here's if you kind of want to, this is just my little quick drawing of it. If you want to think of it as like a box, you can think of it like that, with deoxygenated blood in blue and oxygenated blood in red. But again, note that there are 4 pulmonary veins, 2 from the left lung and 2 from the right lung. So then zooming in on like those layers of the heart. So remember, there's the endocardium, myocardium, pericardium. The endocardium is, and we'll talk about this more, but the endocardium is just like a very thin lining. It's literally like the part of the heart that you see if you were to like dissect it open, like this part. This would be like all endocardium. So this all inner like background is endocardium. The myocardium is the actual like thickness of the wall, like the actual contractile cells pumping blood. That's the myocardium. It's made up of like muscle cells, smooth muscle cells, or not smooth muscle, but like contracting muscle cells. And then the pericardium is like this massive layer. It includes the epicardium, but kind of, I tried to color coordinate it because it's kind of confusing, but you can think of the pericardium as having 2 main layers. There's a fibrous layer and a serous layer. The fibrous layer is like, that is like a thick, tough, like that is protecting the heart from any sort of trauma that would happen. It's very thick, it's very tough, it's fibrous. The serous part is just like an extra kind of padding, but the serous pericardium can further be broken up into 2 layers. So we have fibrous here, and then we have serous, which can be broken up into 2 layers. The first layer, the innermost layer, is called the visceral layer of the serous pericardium. This is like your true epicardium. So like endocardium, there's an epicardium. Epi means on the outside, endo means on the inside. So here's your epicardium. It's also known as the visceral layer of the serous pericardium. And then there's a pericardial cavity, which separates the second layer of the serous pericardium, which is the parietal layer of the serous pericardium. This is very similar to like your pleura, and you'll see there's a lot of connections between like the pleura and the pericardia. One of those things is, remember, with pleura, you can get a pleural effusion, which is where the pleural like cavity fills up with fluid. You can get the same thing in the heart. You can get a pericardial effusion, where the pericardial cavity, which is this like blue layer here, which is in between the visceral layer of the serous pericardium and the parietal layer of the serous pericardium, fills up with fluid, with blood, with whatever. That's known as a pericardial effusion. And then I talk about it down here. This is what fills with fluid in cardiac tamponade, which I'll talk about in like 2 slides. But another fun fact is we're going to talk about innervation to the heart, the sympathetic and parasympathetic innervation to the heart. But I wanted to point out the pericardium itself. So just the pericardium itself has its own kind of innervation. It's innervated by the phrenic nerve, which is like a throwback from poem, right? So it's just like another weird fun fact, like the pericardium has its innervation from the phrenic nerve. So my quick path tie-in is pericarditis. So it's literally when the pericardium becomes inflamed, and you can look at itis. This ending usually means inflammation. So this is inflammation of the pericardium. Many causes for this. A lot of the times it's like a random viral infection or something that they don't really know. It's just like you get inflammation. This is my buzzword B. I put like random like little buzzwords throughout like my PowerPoints, and it's like if you see a prompt mention this, it's a buzzword for this condition. I have a lot of buzzword Bs in my immunology PowerPoints when I teach you guys immunology at the end of the year. But so here's a buzzword B. So if you are reading a vignette and it says that there's a patient, usually it's like a younger patient, so you're really not thinking like heart attack. It's usually like someone in their like late 20s, early 30s, and they're having chest pain, but then it feels better when they lean forward, like this positional chest pain that gets better. That is pericarditis. That's a buzzword for pericarditis. And then if they want to confirm it, they'll do an EKG. And this is what you want to look for in EKG, diffuse ST elevations. And again, I know ST elevations are like, oh, that's a heart attack. Like, oh my God. But if you look, every single lead is going to have these diffuse ST elevations in every lead, or almost every single lead is going to have these these ST elevations. And you can see them really clearly here. But yeah, so that's like the first path tie-in. The second one is cardiac tamponade. So like I said, pericardial effusion, that's going to be when the pericardial cavity, which is that layer in between the visceral and parietal serous pericardium, are going to basically fill up with blood, with fluid, with whatever. It's just going to fill up. That's a pericardial effusion. And if there's too much fluid that builds up, that can lead to a pathology state known as cardiac tamponade. And cardiac tamponade is basically when the heart is like underwater. And you would think all the symptoms that would happen if the heart is underwater can be thought of as what's known as Beck's triad. So Beck's triad is a triad that defines cardiac tamponade. And again, you don't really have to memorize. Just think about like the heart being like drowning in water. And that's why I like this med comic for it, because it's literally like what's happening. So there's distant heart sounds. I mean, imagine like when you're underwater, you try talking, it sounds kind of muffled, like distant muffled heart sounds. You're like, oh, like, yeah, it sounds weird. That's like what it's going to sound like. It's going to sound like the heart's underwater. You have jugular venous distension. We'll talk about that when we talk about like the venous system. But basically like the superior vena cava drains into the heart. So if the heart can't pump effectively because it's underwater, it's going to backflow, and then it's going to look as like distension, just like they're going to get really big in the neck. And then you see decreased arterial pressure, hypotension. Again, the heart can't pump effectively if it's like literally in a box of water. And then the treatment for this is another kind of anatomy tie-in. So that's in this image here. You do a pericardiocentesis. So pericardiocentesis, the anatomy tie-in is where do you do pericardiocentesis? So this is a netter image of tamponade, basically. And you see like we have the jugular venous distension, we have the muffled heart sounds, we have the venous pressure that's sorry, not the venous pressure. The venous pressure elevated is your jugular venous distension. Here's your decreased arterial pressure. So this is like your hypotension. And basically it's showing like the pericardial cavity around the heart is filled with blood. So what you want to do is you want to do like the same thing you would do for like a pleural effusion. You want to get that fluid out. So you inject a needle, but you really don't want to hit the heart. If you hit the heart can go into this random rhythm, and it can just cause like all sorts of issues for the patient if you hit the heart. So again, knowing the anatomical location of where you put this needle in is super important. So they call this location Larry's point. So Larry's point, another name for it is the left infrasternal angle. So I found this picture. I really like this picture. And it's basically like if you were to draw a line from the xiphoid process down to the belly button, and then if you were to draw a line on the left side, so again, this is the left side, the right side. If you were to draw a line from like the left side, like the left costal margin, so just following the ribs down, there's this angle in between the two that's called your infrasternal angle, but we're on the left side, so it's your left infrasternal angle. So what you want to try and do, and I have this picture over here to kind of show it better, is you want to try and get the needle like as close as possible to basically where the infrasternal angle starts. You want to slide it in there, and then if you notice, you shouldn't hit the heart, you should only hit that pericardial cavity. And then you can just drain the fluid, and the patient should, hopefully the heart should go back to normal on its own. All right, so then just highlighting some important structures. I wanted to give you as much gross anatomy as possible. It's hard to kind of do gross anatomy without a cadaver, but I wanted you to see some real life pictures of the heart. Two things I want to point out right away before even starting. Here's what's known as your thymus, and you may or may not see a thymus in pictures of the heart. It's an immune structure. It actually degrades after like a few years. So only children really have thymuses. But it's normal if it's there. If it's not there, it's still normal. So this would be like a child. This would be an adult over here where the thymus isn't there anymore. The second thing to point out is as soon as you were to open like the chest cavity of like a cadaver, you wouldn't see a heart, you'd see the pericardium. You'd see this thick, like ropey, like you're like, what is that? It looks like someone put like a fake thing there. It's the heart, and it's just covered by this very thick pericardium. Okay. And then other things to kind of point out is you can see the superior vena cava like right away. You can see the, we're going to talk about these later, but the thoracic duct and the left recurrent laryngeal nerve, these have like implications for anatomy, so we'll talk about them. And then over here, if we were to cut away the pericardium, the second thing I want you guys to notice is how the heart is oriented in the chest. So right away, if you notice right behind like the chest plate is the right ventricle. So the right ventricle is front and center. It's center stage. It's the one that is, that's kind of how the heart is positioned. It's like the right ventricle is front and then pointing down to the side. So the left ventricle is over, well, not the left ventricle, but the left, like the apex of the heart is down here. Right ventricle's here. And then there are these things called auricles. So you have a right auricle and a left auricle. Another name for those are atrial appendages. And they are literally just, they don't do anything. They're appendages. So kind of think of like your appendix. Your appendix, it doesn't actually have a role. It's just there. That's kind of like these atrial appendages. They're just kind of there. And the auricles are more so like a good a testing anatomy point to be like, what is this? And you're like, oh, that's the right atrium. Or like, what is this? And it's like, oh, that's the left atrium. Those are the appendages. They sit on top of the left and right atrium. And clinically, why they become relevant is like if you guys are doing like LIs on atrial fibrillation, you'll learn that like in AFib, the heart doesn't pump properly. It kind of just like quivers. So you can imagine blood is just kind of staying in the heart. It's kind of like with tamponade, right? It's just kind of like staying there. But since it's quivering, the blood is still moving around. It's just not moving anywhere. It's just staying in the heart. But since the heart's quivering and it's moving around, it can actually get into these auricles. And these auricles, they're just like these little pouches. I have like a picture of them later. The blood kind of just like stays there, and then the blood can clot. And this is when you can actually get clots in the heart. And then once the heart goes back to normal, it can send the clots places. It can send them up to the brain. You can get a stroke. It can send them down to like the GI system, and you can get like GI ischemia and stuff like that. So that's kind of how AFib leads to clots and to strokes and stuff. It's usually because of these auricles, because it's allowing blood to kind of pool there for like extra time. They're like little cul-de-sacs. I'll show you a picture of them when we cut the heart open. But again, you have your right ventricle here. You do have your left ventricle somewhere over here. And then the right atrium is going to be underneath of the right auricle, basically. And this is something that I mentioned in the live session. Whenever you see a slide like this is a screenshot from like the holy grail of boards studying for anatomy. There's like this PowerPoint that floats around, and it's like all the anatomy that's going to be asked on boards is in this one PowerPoint. I went through it before I made this PowerPoint, and I took out at least the relevant anatomy from that. And I at least highlighted what I thought was important to know for first year. And don't worry, I'll send you guys that PowerPoint second year when you're board studying. But for now, whenever you see like a slide like this or like random circles and stuff like that, that's from the PowerPoint. Okay, but at least you can see like, oh, this is boards relevant. Cardiac shadow, absolutely must know the cardiac shadow. What makes the cardiac shadow? I mean, I know we were doing tons of chest x-rays and palm, but a lot of the times when you do chest x-rays, you're trying to look at the heart. You're trying to look at features of the heart as well. So you should still be ordering chest x-rays in your cardio block right now during your cases. So anyway, like always, this is the thing I said yesterday too. You have to think always with anatomy. You have to have anatomy brain, which gets you in trouble for real life because I now think of everything and even in life as anatomy brain. And I'm like, oh, it's on the right. And they're like, that's literally the left. And I'm like, oh yeah, you're right. So the right, you have to imagine like with anatomy brain, it's like reverse. You're like, they're facing you. So like this is their right side, this is their left side. I always say anatomy brain, right, draw your right, draw your left, just to kind of get into the habit of doing that first year. But anyway, so what's making the right border? So here's your sternum, like right down the line. It kind of is superimposed over the vertebra. So you can kind of see the vertebra here too. The right side is made up of the superior vena cava. It's just like a little baby bump. That's your superior vena cava. And then your right atrium. So that's the right cardiac shadow, basically. On the left side, we have a bunch of other structures. We have your aortic arch, which is kind of here. We have your pulmonary trunk, which is here. Then we have the left, they say the left auricle is here. No one really thinks of the left auricle being there, but it is there. It's not the left atrium, so don't get confused. And then the left ventricle. So notice though, you can't see the right ventricle on a chest x-ray because it's right in the front. You can't see it. And you can't see the left atrium. The left atrium is directly behind the right ventricle, so you can't see that on chest x-ray. Auscultation sites, these are just, you need to know these, especially for murmurs. It'll help you like differentiate like a type of murmur. If a murmur sounds the same, the only way sometimes you can differentiate is like where you're listening in the chest. So the mnemonic a lot of people use is all physicians take money, or apartment M. Some people do like, oh, it's apartment M. But it's just the location. It's just like the valves that you can hear in these various locations. So the first location is your right second, again, anatomy brain, right second intercostal space. You can hear your aortic valve. So that's your A. The left second intercostal space, you can hear the pulmonic valve area. So that's P. And then you go to left fourth intercostal space. Sometimes they'll even say like left sternal border, like low left sternal border. Same thing. That's your tricuspid area, and then left fifth intercostal space, but make sure you're mid-clavicular. So find the clavicle, and it's I did not draw that properly. There we go. Kind of. Mid-clavicular, that is your mitral. That's where you can hear the mitral valve. So that's like that space. Okay. So you should know those and like the mnemonic for the order. This is how when you guys are learning about, I don't know if you've actually, I don't know for OCS when you do learn this stuff anyway, but like when you're listening to SP patients' heartbeats and stuff, you need to do it in this order, and these are the valves that you're listening to. All right, so kind of zooming in a little bit now on like more of the gross anatomy. Now we're kind of like diving into each side of the heart. So this is the right heart. This is where they open up the right atrium, and then this is more of like the right ventricle. I don't know why it's not here, but this is your right ventricle. And I highlighted again things that I thought are important landmarks to recognize. So the first one I want to point out is your right auricle. So see how the auricle literally looks like this just like cul-de-sac of nothingness? This is where blood can kind of pool in something like atrial fibrillation, and then you can get a clot. You can get a clot here. And then when the heart goes back to normal, it can shoot out that clot. Superior vena cava comes from up here. It goes right into the right atrium. Inferior vena cava, same thing. It empties right into the right atrium. I didn't highlight the fossa ovalis, but we are going to talk about like the foramen ovale a little bit with embryo. The fossa ovalis is the remnant of the foramen ovale after it closes. So that you can see that in the right atrium as well. That's a good anatomy tie-in because during fetal development, the foramen ovale allows for the right and left atria to communicate with each other. So that's why you can see it in the right atrium. The opening of the coronary sinus, this is basically where the coronary blood flow drains. So we're going to talk about coronary blood flow, but the heart does need its own blood supply, right? The heart needs blood. I mean, blood carries oxygen. The heart needs lots of oxygen. So the heart still needs blood. But anytime there's an artery, there's also veins. So the coronary arteries that go to the heart also need to be drained by coronary veins. The coronary veins empty into the right atrium via the coronary sinus. And we'll talk about the coronary sinus, but I wanted to talk about like the Thebesian, like they talk about like, oh, it's the Thebesian vein, which if you guys remember from poem, that is one of the physiologic shunts in the body that kind of like it messes with the CO2 and oxygen concentration in the blood because we're dumping in more deoxygenated blood than we should have because you need to factor in the heart with that. So that's kind of like why it affects it. It drains directly into the right atria, so you do get a little drop in like oxygenation basically. Other things too, there are things called pectinate muscles, which I didn't highlight, but those are kind of like the muscular muscles of the atria. And then this will become more important for like things like the embryology system when we talk about embryo. And then all the pectinate muscles kind of terminate in the crista terminalis. And it's just kind of like, again, where all those pectinate muscles kind of come together. And you can see them here. In the ventricular side, there are a lot more, so a lot of the same structures that we already talked about, you can't see it anymore. The first main one that you see is the tricuspid valve. So remember the tricuspid valve is on the right side of the heart. It's between the right atrium and the right ventricle. So here's your tricuspid valve. There are 3 cusps. It's really not super important to know like which one's the anterior cusp, which one's the posterior cusp. It really doesn't matter all that much. What's more important is that there are 3 of them. That's why it's tricuspid. Not only that, what becomes more important for like implications for certain murmurs are understanding that these cusps are linked to what's known as chordae tendineae. So chordae tendineae are like these little strands here that connect the cusps to this muscle underneath, which is known as papillary muscle. So we have cusps, chordae tendineae, papillary muscles. When I was explaining this during the live session, I was saying I think of the all the valves as like parachutes. So like the cusps are the actual parachute, and then the chordae tendineae are like where you're holding down the parachute, and then your body is like the papillary muscle. So that's kind of how I think of it, and that's actually how the valves open and close, is kind of like a parachute. You can also see from the right ventricle the pulmonic valve, because again, it connects directly from the right ventricle, and the pulmonic valve is a semilunar valve, which is there's 3 like cusps, but they do look very different. Obviously, these look entirely different. The tricuspid and these types of valves look very, very different, but it is a semilunar valve. There are 3 cusps. It's just like the aortic valve. We'll talk about that. And then the one that I put the star next to, this is what's known as the moderator band. And the moderator band is like basically just thick muscle that comes off of the interventricular septum, and it connects to like the wall of the right ventricle. And why this is such an important thing is because it doesn't do anything, but it's a good landmark. The left ventricle does not have a moderator band. So a lot of the times, like with gross anatomy, it's like, oh, you're in the right ventricle or the left ventricle, and you can't tell like which valve is above it, and you're like, whatever. Look for this moderator band. So it literally is like this horizontal line that's coming off the IV septum connecting to the wall. The left ventricle doesn't have it, which you'll see in a second. So it's a good landmark. And then the last thing I wanted to mention was this trabeculae carnae. Again, with embryo, certain embryonic structures, it'll say like, oh, this develops into the trabeculated version of the ventricle, or the smooth portion of the ventricle. The trabeculated portion is the portion that has these like basically pectinate muscles. That's going to be like those are the trabeculated portion. Okay, so that's what it's referencing. It's just like the ventricle wall versus like the atrial wall. It's pectinate muscles versus trabeculae muscles. The left heart. So right away, so this is going to be the atrium up here, and then the ventricle. Well, this is mostly going to be the atrial and the ventricle. This is just the ventricle. So LA and LV, kind of, sort of. And this is where they just kind of took off the mitral valve just to kind of show you more of like these deeper features. But right away, look at the auricle. Again, this is a really good picture to kind of see, like, it looks like a tunnel. Like, it literally looks like a tunnel. So if blood gets stuck in there, it can pull clots. Here's where you're going to see in the left atria, you're going to see all of like the 4 pulmonic veins enter through here. So they're only showing the right ones. They probably cut away the left ones, which is fine, but all 4 of them are going to drain into the left atrium. This right here is probably like the fossa ovalis, but now from the other side. Remember, the fossa ovalis, foramen ovale connects right atria, left atria. You can see it from this side as well. You can see different portions of the septum. So the muscular portion of the IV septum versus the membranous portion of the IV septum. I only really differentiate between the two, again, because of embryo. Certain parts develop into the muscular versus the membranous. What else? You can also see kind of sort of the aortic valve under here, which is going to be, I actually can't see it here. So the aortic valve is also a semilunar valve. It has these 3 cusps. It looks exactly like the pulmonic valve, but it's connected to the left atria, or the left ventricle. And then if we go over here to look at the mitral valve, another name for it is bicuspid valve, because there are 2 cusps. So we have an anterior and a posterior cusp, but it's the same construct, connected to chordae tendineae, connected to papillary muscle. And again, that is how the valve opens and closes. It's like this parachute opening and closing. So here are the left pulmonary veins. So there's 2 of them. Drains right in here. The right one's over here. And then you can also see the aorta on this side. And then another thing too, just again, notice the thickness. So look at the thickness from the left ventricle versus the thickness of the right ventricle. It's completely not even comparable. So again, these are all good landmarks to be like, okay, yes, I'm in the left ventricle. Oh yeah, also notice no moderator band. There's no just like horizontal line coming off of the IV, or the IV septum would be. So, but there is like a very clear one in the right ventricle. So again, landmarks to help you know like what part of the heart you're in. Another thing too, it's absolutely critical to be able to see a picture like this where they're showing like this would be a transverse section of the heart where like they separate the atria from the ventricles, and it's absolutely important to understand like is the heart in systole or is the heart in diastole? So remember, systole is when you're pumping blood out to the rest of the body. So we obviously want the valves like the mitral and the tricuspid valves closed. but we want the aortic valve and the pulmonic valve open because that's the whole point of systole, is to pump blood out to the rest of the body, pump blood to the lungs. So if you're ever confused, look for what, and like on the side of the heart, what side of the heart we're on. Here's the mitral valve because there are 2 cusps, 1, 2. Here's the tricuspid valve because there's 3 cusps, 1, 2, 3. So you're like, all right, this is the right side of the heart. This is the left side of the heart in this instance. The aortic valve is always going to be in the middle. So even if they flip this around to try and confuse you guys, it's always going to be in the middle. And the pulmonic valve is always going to be like the furthest away from like the mitral and tricuspid. Okay, so this is during systole because this is when the aortic and pulmonic valves are open. Over here, this is how it would look in diastole. So you can see right away the aortic and pulmonic valves are closed, and then the mitral and tricuspid valves are open. So again, just really critical to know. This is like just an anatomy thing you should absolutely know, because then they can tie this into murmurs. They can tie it into, you know, what part of the heart is damaged or whatever, and they'll have you point. So just really be able to tell systole, diastole. I put some more pictures here because, again, it's super critical. So, again, I tried to find different orientations, like just to always remember, like, okay, the aortic valve is always going to be in the middle. And then you can see bicuspid or tricuspid to kind of help you figure out where you are. And then here are some gross anatomy pictures. So I just wanted to show you guys some gross anatomy pictures as well. So remember, the aortic valve is always going to be in the middle. Here's your mitral valve right here because there's 2. And then the tricuspid would be the 3 cusps. It's a little harder to see with the from the cadaver pictures, but again, just kind of find your aortic valve, try and find either mitral or bicuspid versus the tricuspid, and then you can kind of orient yourself that way. All right, so next comes to this idea of ostia. So remember how I said the aortic and pulmonic valves look exactly the same because they're just semilunar valves, there's 3 cusps. The aortic valve only have what's known as ostia, and ostia literally means like holes. So they have these holes in them, and the holes are actually for the right and left coronary arteries. So again, remember how I said like the heart needs blood itself? Well, it needs oxygenated blood. So where is it going to get oxygenated blood? Because oxygenated blood is coming from the heart. So it actually like has these little holes in the aortic valve. So imagine when the left ventricle pumps blood and it sends it out through the aortic valve, it actually does like a little swerve motion. The blood can actually go through these little holes or these little ostia to go to both the right and left coronary arteries. And then it can perfuse those, and then the coronary arteries can perfuse the heart. Okay, so a single one is called an ostium. Both are known as ostia. And again, it's another landmark, a gross anatomy landmark to be like, yes, this is the aortic valve. If you see this without these little holes in them, that would be the pulmonic valve. So some take-home notes so gross anatomy take-home, left ventricle wall thickness, way more than right ventricle wall thickness. The right ventricle has a moderator band. So again, no matter where they kind of show you, they open up the heart for you and they kind of show you and they're like, which ventricle are you in? Look for the moderator band. That's how you know you're going to be in the right ventricle. Papillary muscle connects to chordae tendineae, connects to valve leaflets, and valve leaflets, I mean mitral and tricuspid. The aortic valve, pulmonary valves, these are semilunar valves. The aortic valve has holes for the coronary artery blood supply. Those are called ostia. And then just general direction of blood flow. Deoxygenated blood goes from SVC and IVC and also coronary sinus to the right atria, through the tricuspid valve to the pulmonary artery out to the lungs. Oxygenated blood returns through 4 pulmonary veins to the left atria, through the mitral valve, into the left ventricle, out through the aorta. So innervation to the heart. So the heart gets sympathetic innervation from levels T1 to T4. This is the extent of anything neuro you need to know. You just need to know like what is innervating. You'll make a lot more sense with neuro when you get to it at the end of the year. It'll like, everything will come together in neuro. You're like, oh my God, wow, everything makes sense now after I had neuro. But just know like the sympathetic trunk levels that supply the heart, I think it's the same as the lungs, but it's T1 to T4. Actually, I'm pretty sure it's the same as the lungs. Parasympathetic innervation to the heart is your vagus nerve, and your vagus nerve sends off this branch, so it is your vagus nerve. But again, just wanted to highlight the left recurrent laryngeal nerve that I mentioned earlier, because notice that the vagus nerve kind of sends this branch underneath the aorta. It literally loops under the aorta and then goes up and it innervates the rest of the trachea so that you're able to like speak properly. If any part of the aorta gets compressed, we'll actually talk about like a mediastinal anatomy like tie into this. But if any part of this area gets compressed, you can have hoarseness. And a lot of the times they'll be like, oh, like what nerve is implicated with hoarseness? And it's the left recurrent laryngeal nerve, which is basically a vagus nerve branch. And the other thing I wanted to mention is don't forget that the pericardium itself is innervated by the phrenic nerve. So there's technically 3 nerve roots that are innervating the heart. We have the vagus, we have the sympathetic trunk from T1 to T4, and we have the phrenic nerve for the pericardium only. Blood supply. So if there's absolutely nothing else you take away from this entire PowerPoint, please no blood supply. This is very high yield. You can imagine why. This is like in heart attacks. This is what happens in heart attacks, is that there's a blockage in the coronary arteries. So we're going to talk about the left and right coronary arteries. So I want you to notice right off the bat, here's your aorta. Here would be the ostia. So you have a right, and again, anatomy brain, always anatomy brain. So this is right, this is left. So you have your right ostium, which would lead to the right coronary artery, and then you have your left ostium, which would lead to the left coronary artery. If you notice, the left coronary artery like branches almost immediately, and it branches into the left circumflex, and it branches into the left anterior descending, or the LAD. Another name for it is like the anterior interventricular artery. The right coronary artery, it sends off these like little branches. They're not as important. You should still know them. I have like a little thing later of like what I think you should know, but just notice it's kind of sending off these branches, and then notice it kind of loops around the heart, and that has to do with dominance of the heart, which I'll talk about in a second. But other things to mention is that notice every artery has a corresponding vein. And remember, all arteries are paired with veins. It's just the way of the world. It's just how it was intended to be. So arteries are going down, veins are going up, and then all these veins are drained into the coronary sinus, which I thought was the next slide. It's not the next slide. But what I wanted to also talk about too is what each coronary artery is supplying. So the right coronary artery supplies the right side of the heart, which you can obviously see nicely right here. And it indirectly supplies the back of the heart in most instances. And this is where heart dominance kind of comes into play. The left coronary artery branches into the LAD right here, which supplies the anterior part of the heart, the IV septum, the interventricular septum, and then the left side of the heart. So like right here, and then the left circumflex also supplies the left side of the heart, but it also supplies like the very lateral part of the heart. So this is again from that PowerPoint that everyone uses second year to study for boards. I guess on whoever made, and again, this is med schools across the country. I have no idea who made this PowerPoint. It's just the one that goes around. But I guess on this person's boards, I think the person that made this went back and circled everything that they had gotten a question on boards, just to have people like more aware of the types of questions that they get asked. So this is an example, like this circle that he put on. I guess they asked about the marginal artery, which is a branch of the right coronary. So here's your marginal artery right here. It's a branch of the right coronary. So the question was probably like, which artery supplies the right ventricle? And it's like the marginal branch of the right coronary artery. But just kind of wanted to show you like more on the RCA. It supplies the right atrium, right ventricle. This term anastomosis, this is going to come up for like every block moving forward. It's basically when like 2 separate arteries join. So like this example is like, oh, so the RCA anastomoses with the left coronary artery. So we have the right coronary artery doing its own thing, and then the left coronary artery is doing its own thing, and then they kind of meet in the middle, and then they join, and now we have like they like join together, and now we have like this dual blood supply almost. That's known as like an anastomosis. It comes up a lot in GI block. Anastomosis are really important. Whenever you see an anastomosis in GI block, it's really important to remember those. But if you see this term, that's what it means. It's just like a connection between like 2 seemingly like not similar arteries. It's not really the same as like collateral circulation. Collateral would be like extra branches. This is like the branches are connecting. Okay. So that's the RCA. More on the left coronary artery, it branches into the LAD and the LCX, which is what we talked about. This is more just here for your knowledge. Okay, so now if we look at like the back of the heart, again, just kind of like wanted to point out immediately the coronary sinus. So the coronary sinus, this is again where all the coronary veins are now draining into the coronary sinus. And then remember from that gross anatomy picture, there's an opening in the right atria for the coronary sinus. It just dumps into the right atria. That's like one of your physiologic shunts. That's like your Thebesian or whatever blood supply. That's a physiologic shunt. A fun fact about the coronary sinus, this is the most deoxygenated blood in the entire body. And again, it's because the heart uses so much oxygen that it strips the most amount of oxygen from the blood that it's receiving. So when the vein drains it, it has like the littlest amount of oxygen in it compared to like every other organ in the entire body. That's why. So just a fun fact. But now we're going to look at the PDA. So the PDA, the posterior descending, another name for it, posterior interventricular artery, that supplies the posterior part of the heart as well as the posterior part of the IV septum, which I'll talk about in a second. When they talk about the PDA, this is kind of where heart dominance comes into play. So heart dominance is basically which artery sends a branch off that becomes the posterior descending. And I want to put a disclaimer here, 90% of the time, and actually when you're doing practice questions and stuff like that, if the question is not specifically asking about dominance, it's like not trying to test your knowledge of this concept, it's usually going to be the RCA branches into the PDA. Okay, so even with like heart attacks and like when they get into that stuff, like when you get to that later with some path, keep that in mind. The RCA supplies the PDA most of the time. But if they want to talk about dominance and be tricky, in 10% of the population, the posterior descending is actually fed from the left circumflex. So here's your left circumflex. Where's the circumflex? Right here. So here's your circumflex. In 10% of people, it actually does this, and then this connection wouldn't be here off of the RCA, which is super weird. But again, it's just a dominance question. Also, like an even smaller percentage of people, I don't even know what the percentage is because there's no room for it in 100%, 90 and 10, they're co-dominant. So they have both a branch, like the PDA comes from the LCX as well as the RCA. So right-sided dominance is normal people. Your RCA supplies your PDA. Left dominance, the LCX supplies the PDA, and then in codominance, both, like in this image, supply the PDA. But in most images you see of the heart, questions that you do with the heart, the PDA comes from the RCA. And this is kind of where a good question came up yesterday. Actually, let me go to the next slide. So the RCA supplies the SA node and the AV node. It just sends off these little branches. It sends off an AV nodal branch, and it sends off, which is here, and then it sends off an SA nodal branch. And the question that I got yesterday was, well, technically, isn't that the AV nodal branch coming off of the PDA? Like, isn't it technically coming off of that? 100% correct. And this is where a lot of the time I went into some rabbit holes. I even had conversations with Dr. Scally, Dr. Papa, like everyone in PBL about this because I couldn't find a source that agreed on this. And this is basically what Dr. Papa, who's a cardiologist, you'll have him second year PBL, he is like, it's RCA. Just go with RCA. Just go with RCA. And even when you start doing UWorld questions second year, when they even ask about heart dominance and like AV node, SA node, they always just they go with RCA versus PDA. Okay, so it's just like one of those things. If you want to look it up, you'll go into some deep rabbit holes. But technically, yes, it's coming off the PDA, but the RCA supplies the PDA. So you can just say the RCA supplies both the SA node and the AV nodes. Okay, and for your exam, it will be the RCA has these nodal branches. Okay, and then here are just images of it. Okay. The interventricular septum receives dual blood supply. So again, I want to just point out that this is a right dominant heart. This is the same if it was a left dominant heart. It's the same in any instance, but I just wanted to point out this drawing is of a right dominant heart, which again is the normal heart that would be drawn. But here's your right coronary artery, sends off a branch to the PDA. This is right dominance, but it would be the same if it was left dominance. So the IV septum has this dual blood supply. So you can imagine the IV septum is here. So it receives a posterior blood supply from the PDA, and it receives anterior blood supply from a certain branch that comes off of the LAD. So you'll see like the PDA supplies the posterior 1/3, and then the LAD supplies the anterior 1/3 of the IV septum. So here is kind of like if you had to kind of draw out the certain branches, what I said, like you should kind of like have certain ideas of like these other random branches. So let's start with the RCA. This supplies the right side of the heart, and it sends off your SA nodal branch, and then it like indirectly sends off an AV nodal branch, but it still counts. And then it sends off a acute branch or right marginal. This is the one that was circled in that PowerPoint. This supplies like the right ventricle. 90% of the time, the right coronary also sends off a branch that is the PDA. The PDA supplies the posterior wall. On the other side, the LCA has an LAD branch as well as an LCX branch. So the LAD branch is the anterior wall, the IV septum, blah, blah, blah. LCX is the lateral wall, the left side of the heart, blah, blah, blah. 10% of the time, it turns into the PDA. So this wouldn't be here if that's at 10% of the time. But if it's codominant, they would both be here. So this this branch and this branch would both be here if this was codominant. And then notice that the left circumflex as well also sends off a branch called the obtuse, which basically is the left marginal. So the right marginal, which supplies the right marginal, which supplies the right ventricle, is the acute, and then the left side equivalent is called obtuse. So I think that's kind of cute. I don't know. And then also on here I have in blue the veins that drain these arteries. So again, just kind of getting into the habit. Every artery has a corresponding vein. So here are those corresponding veins. They're not super important, like on the low key. They're really not that important. They're like a mix of like names of cardiac, like middle, small, large, whatever, or great. I think what's more important to understand is that they all drain into the coronary sinus, most deoxygenated blood ever because of how much oxygen is stripped from the arteries. And then they drain into the right atrium. Next thing you have to kind of know how to do is look at an angiogram and be like, okay, is this a right coronary angiogram or a left coronary angiogram? And an angiogram is usually used if like someone wants to see if there's a block, like the doctor wants to see, is there a blockage in this patient? Like, are they having a heart attack? Where's like a stenosis or a narrowing? Like, is that here? So they'll do a right and or left coronary angiogram. Usually they do both. But this is the right side, and kind of like what you're seeing here is directly off of that ostia, which would be up here. It comes off of the right coronary artery, and then it goes down. It sends off these like little branches that aren't super relevant. I kind of drew like just very quickly, like if you want to kind of be like, oh yeah, like here's a rough drawing of these unimportant ones. But what's really important to know is this loop. So see how it kind of looks like it loops? It is looping. The heart is not here. It's just the coronary vessels. So imagine this loop is it going behind the heart, and then it sends off its posterior descending branch. Okay, so it loops, it goes behind the heart, and then it sends off its PDA branch. Here's your AV nodal branch. Here's your SA nodal branch up here, your marginal branch, and then you have your PDA over here. Left coronary angiogram, I just want you to notice right off the bat how different it looks from a right coronary angiogram. So here's your right coronary, there's a loop. Left coronary, no loop, and it also just looks a little different. I think they look like little tree branches like hanging down. And again, just imagine on the heart, like remember on the heart, it's kind of how it looks. They look like little tree branches like hanging down versus the right one, it's just here and then it all of a sudden disappears because it goes behind the heart. That's the loop. So on here, this would be the, so again, this is right out of the ostia. So here's your LCA, and then it goes into the LCX, and then it goes into the left anterior descending, which is here. So these are at least the main arteries to know. Then there's all these other other branches that come off of it. Here's your obtuse branch. It comes off of the LCX. Remember, it's like the equivalent of the acute branch on the right side. I got the question in the live session, how would this look different for a left-sided heart person or like a codominant heart person? And I don't think they'll ever show you that. I just don't think they would do that. I think that's too tricky. Even for boards, I think that's too tricky. But for your exam, they definitely won't do that. They'll just I think they just kind of want you to understand that the right coronary artery loops because 90% of the time it needs to go behind the heart anyway. But I'm assuming if like a left dominant heart or a codominant heart, there would also be like another branch like coming off of the circumflex, and it would look like a loop as well. Okay, so I got this question yesterday, and we had like a little bit of a discussion on it. I know like this is a physio concept. This is more of like anatomy and like path here and there, but I think it's good to talk about because this is like a good concept to talk about. Here's a graph. So remember, graphs are important to know. So this is from that CV Physio website I was telling you about, Clabunde's website. So coronary blood flow. Coronary blood flow, this is a graph that basically shows blood flow through those coronary vessels, so the RCA and the LCA. Usually there's only one graph, and it usually just shows the LCA because that's the more important one. But there can be another one where like underneath of this, they would show the RCA. It would look a little different, but it just has to deal with the left side of the heart needs more blood than the right side anyway. But all this is pretty much showing is it's showing like, okay, here is blood flow down here, so coronary blood flow, so through those coronary vessels, RCA, LCA, and up here is aortic pressure. And the only reason they put aortic pressure here is to show you like where systole is happening, where diastole is happening. So this is actually the top part of like Wigger's diagram. Remember, I was like, oh, you should know Wigger's diagram. Wigger's diagram does have a portion that shows aortic pressure. And usually aortic pressure is just your blood pressure, right? So like the top of systole, it's at 120. The bottom of diastole, it's at 80. That's your normal blood pressure. You can find pulse pressure from here. So remember, pulse pressure is going to be the difference between systolic and diastolic. Usually normal pulse pressure is around 40 because that's 120 minus 80. So all this is really kind of showing you, this image here is showing like during systole, so during systole, which goes from here to here, coronary blood flow is the lowest. And this is where we had kind of a discussion yesterday, and someone chimed in, thank God, because I don't remember, I wasn't prepared for my cardiac physio that in that much depth. But the reason why it's lowest in systole is because the coronary vessels are getting compressed because the myocardium is contracting. So the myocardium is contracting, it's trying to get blood out. It actually squishes the coronary arteries. And it's kind of similar to if you have I'm making you guys think about pulm a lot today, but if you think back to pulm, pulmonary vascular resistance. Remember how it's like, oh, if the resistance goes up in the alveolar vessels, but it can go down in the extra-alveolar vessels and all that jazz with pulmonary vascular resistance. It's kind of the same idea. It's just resistance and flow are opposite. So usually with resistance goes up during like when at least with the lungs, when you're forcibly exhaling, resistance goes up because they're getting squished. This is the opposite. It's now blood flow goes down because they're getting squished, because resistance and blood flow are opposites. Does that make sense? I'm asking that as if anyone can answer. But a lot of the times, even Klabunde on this CV physio website, he says like it's extra vascular compression. And I have like an image to show you what that kind of looks like, how you can visualize it. But what's really important to understand is your coronary blood flow is the highest during diastole. So you can see like during diastole, blood flow shoots up. And you can imagine it is because the heart's no longer contracting, it's relaxing. So now those vessels are not getting squished, so they can actually relax, and now they can get perfused. So they can actually like get blood, and this is actually when the heart gets perfused is during diastole. That's why. It's because the coronary vessels are actually able physically to perfuse them because they're not getting squished. So kind of how to like visual. So here's an example of like your left versus your right, but usually people just show you the left. But regardless, during systole, here's at rest. So this would be normal. Here's like your right and left coronary arteries. So your RCA coming out of the ostia and the LCA. I didn't really draw it to scale. I just kind of wanted you to see what happens. So again, remember with systole, the heart contracts. So it kind of looks like it gets smaller, which kind of like squishes them, and they get really, really, really tiny. And it's like, that's why the pressure goes down like so much, like it goes down. Then through, at least right off the bat. Usually it goes down like this during the isovolumetric contraction, which I actually like better on this slide. Again, I just love Klabunde's graphs. So see how it goes down? This like what he highlighted in orange would be like your isovolumetric contraction. So that's kind of where it starts to go down a lot because that's where it really gets squished. During diastole, so this is where it shoots up. The reason it's able to shoot up because now the heart is relaxing, it's filling, so they're able to be like really nice and thick. They're able to kind of like actually allow blood to flow through them, and then it can start perfusing the rest of the myocardium. Okay, so just wanted to bring that up because that was a question that was brought up during the live session, and it's a good physio talking point. Like anytime there's graph interpretation, it's going to be a good physio talking point. All right, switching gears to some histology. So want to start talking about vascular anatomy and histology because, again, the vascular system is completely fair game, cardiovascular, CV. So we have to talk about that. So just like with the heart, there are 3 layers. It's just like the rule of 3s in medicine, right? So there are 3 layers of like an artery, of a vein, doesn't matter, of a vascular vessel. That's the one, of a vessel. This specifically is an artery, and I'll show you why you can tell that this is an artery. But first I want to talk about the 3 layers. So the outermost, so look at where the picture's coming from. So this would be the outermost out here. This is your tunica externa. Tunica just means coat. externa, external. You're like, nice, named correctly. Another name for externa is adventitia. Usually it's adventitia for like GI organs. So just notice when you get to like GI anatomy, though there will be like adventitial layers. That's the outermost layer. So that's your tunica externa. This is made up of connective tissue. And we're actually going to talk about two like path tie-ins with like the vascular system where you have like genetic defects in connective tissue. So two main ones are Marfan syndrome and Ehlers-Danlos syndrome, which I have on future slides. Those you don't have to really go into too much, but just understanding those are connective tissue disorders, so you can kind of start to think like, okay, like there's going to be issues with the vasculature in this person because of this connective tissue is like all kind of janky and messed up. It's not going to do a good job. The whole point of the connective tissue is to kind of hold the vessel together and keep it like a nice vessel so it can get blood to where it needs to go. The next layer is the tunica media. This is made up mostly of smooth muscle, which you can see here. That's what the smooth muscle cells look like. They look like little, I don't know, eyeballs. So that's your smooth muscle, but also located within the media is these elastic fibers. So see these elastic fibers, these purple fibers, these are elastic fibers. They're located within the media. This is what makes this an artery and not a vein. A vein do not have elastic fibers, and veins also have a lot less smooth muscle than this, a lot less. And then finally, your tunica intima, your innermost layer. Anytime you have a vessel, it's going to be lined by endothelial cells. You can see them here. They're lined by endothelial cells with like some sort of like basement membrane, which is what they're sitting on. But it's a very, very thin layer. It looks even thicker here than it should be. So I want to show you a histo slide because this gives you a better idea of the tunica intima. Look how thin it is. It looks like it's like not even there. It's just such a super thin line. It's just those endothelial cells. The media layer, again, in an artery is a lot thicker, so it's flanked on both sides with these elastic fibers, which are purple, they're doily looking. That's going to be your elastic layer. And then the tunica adventitia or your tunica externa, kind of the same thing. That's going to be your loose connective tissue, kind of just holding this all together. Two things I want to mention. So the first thing, vasa vasorum. You're going to see this like moving forward and you're like, what is vasa vasorum? It sounds hilarious. Vasa vasorum are vessels that supply vessels. So just like the heart needs its own blood supply, right? The vessels need blood supply. And usually like vasa vasorum are going to be in like bigger arteries that like are doing a lot of work and contracting and need a lot of oxygen. They need blood. So the vasa vasorum are these small vessels that supply these larger arteries. So that's your vasa vasorum. A lot of the times you don't have to recognize them on like histo slides, but it's just kind of understanding that they're there. There are some pathology states where like the vasa vasorum gets obliterated or it gets affected. And that's when it's like, oh, like that's why that happens in that certain pathology state. I will tell you syphilis, the bacteria that causes syphilis, it like completely obliterates the vasa vasorum. So you can see like certain you can also see like cardiac defects in syphilis as well. Syphilis is a very interesting bacteria. Anyway, that's for microimmuno. That's for a later time. But the second thing I want to point out is that arteries are super, super, super not compliant. You don't want them to be compliant. So compliance makes a comeback from poem. Compliance, remember, is like it's the change of pressure over change in volume, right? So I think of a compliance as like if you're able to make something bigger or smaller pretty easily, that's super compliant. It's just going with the flow. It's like, all right, sure, like let's get bigger. You want me bigger? Let's get bigger. Arteries can't do that because arteries need to supply the organs are expecting a certain amount of blood at all times, so they need to be able to give that to those organs. So that's why you see in arteries these elastic fibers. Remember, compliance and elasticity are like opposite. So if you have a lot of compliance, low elasticity, very high elasticity, low compliance. Arteries have very high elasticity because they have very, very low compliance. They don't want to be moving around all the time. Okay, so that's how you can kind of tell like this is an artery. Another way to kind of tell that this is an artery is it's a perfect circle. Again, that's because there's a lot of smooth muscle here and also those elastic fibers. It's keeping it this perfect circle. This is another thing, like if they just showed you this on your exam or on boards, like which one's the artery, which one's the vein? So right off the bat, remember arteries have very thick media layers. So because again, there's tons of smooth muscle there. Veins are a lot thinner. They have a lot thinner media layer. Another thing too is that arteries are like perfect circles. Again, it has to do with not being compliant. They are like, you know what? Nope, we're a circle. You can't change us. Sorry. Like we have so many elastic fibers. Veins, however, they don't have as many elastic fibers, if any. They can do whatever they want. So when you see shapes of veins, they're just going to be all over the place. They can look like this. I have the next slide showing like they can just make all sorts of shapes. They're massive. They're really big because remember, one of the functions of veins is to hold pooled blood. So they can get all sorts of weird looking shapes. Last thing about arteries and veins in terms of anatomy is arteries don't have one-way valves. There's absolutely no one-way valves. This is going to become important to understand, like in certain conditions, why we don't get backflow through arteries. It's really hard to get backflow through arteries, but we get backflow through veins. Veins do have one-way valves. It can kind of like just barrel through those one-way valves if it needs to. That's why if you get like backup of blood, same as the lymphatic system. The lymphatic system also has one-way valves. So that's just like another anatomy plug. Here are pictures of arteries and veins. So again, if they showed you a picture, you can be like, oh yeah, that's the artery, these are veins, that's the artery, these are veins, artery, vein, artery, vein. Usually arteries are right next to veins, like I kind of mentioned earlier. So if you see two on a screen, usually it's gonna be one artery, one vein. All right. So now talking about just the arteries of the body, the first thing I want to mention is definitely know your branches of the aorta. I have pictures of it to show you. You just really need to know the branches of the aorta. It'll just straight up be like an anatomy question. Like they'll point to a branch, be like, what is that? Like, what is this name? You just need to know them. So I kind of drew it here. So blood's coming up through the left ventricle through the aortic valve. And then the first branch is going to come, and again, anatomy brain, right, left. The first branch it's going to encounter is the brachiocephalic trunk, and then the brachiocephalic trunk immediately separates into the right subclavian and the right common carotid. The right subclavian is going to supply the right arm, and I put neuro here because this is more of like a neuro, like you're going to cover this again in neuro. And then the right common carotid is going to branch, which we're not going to talk about that much. This is, again, a very, very neuro thing. Don't even worry about it now. I just wanted to talk about it because of baroreceptors, which I said you should understand what baroreceptors are. The location of baroreceptors, which is an anatomy thing, is at the branching point of the common carotids. So that's why I just want to mention them, but you really don't have to go into like depth of understanding them until you get to neuroblock, all right? So right subclavian does the right arm, right common carotid splits basically into the internal and external carotids, and then the internal and external carotids do various things up in the neck and up in the skull, and they keep branching. You'll do it all in neuro. But at the bifurcation of these carotids, of the common carotids, you have carotid baroreceptors. So it's going to be right at the bifurcation at the common carotids. And the carotid baroreceptors, and this is, again, a physio thing, so it'll make more sense when you do it, but they kind of get their, supply their input or get their afferent fibers through the cranial nerve 9, so the glossopharyngeal nerve. So the baroreceptors actually go to, like, the brain, and those afferent fibers are carotid baroreceptors, okay? That's the brachiocephalic, right subclavian, right common carotid. We keep going. We come into contact with the left common carotid. So the left common carotid is its own branch on the left side, and it's over here. It does the same thing. It also bifurcates into the left, the left internal carotid, left external carotid, more carotid baroreceptors, and then we keep going. Now we have the left subclavian. So again, its own branch on the left side, and the left subclavian does the left arm, and then it sends that blood out, and then it sends the rest of the blood through the abdominal aorta, which we'll talk about next. So blood is leaving through all of these branches. It's going to the head and the neck so it can get supplied, but then the rest of the blood is going to like the abdominal aorta so the rest of the body can get blood. Right here in the aortic arch, there are aortic arch baroreceptors. So another type of baroreceptor. And baroreceptors are basically just pressure sensors. Again, like you'll learn about it with physio. But the anatomy tie-in there is that the afferent fibers for the aortic baroreceptors is cranial nerve 10, so the vagus nerve. So a lot of the times it's like understanding that if you have like the aortic baroreceptors are firing, it's doing so via the vagus nerve. If the carotid baroreceptors are firing, it's doing so via the glossopharyngeal nerve, which is cranial nerve 9. And then here's a cadaver image. Again, if they showed you a cadaver image knowing, oh yeah, here's my aortic arch, here's my brachiocephalic trunk, right subclavian, right common carotid, the second branch of the aorta, left common carotid, and then the bifurcation is off screen up here. And then the the third branch of the aorta is the left subclavian, and it's going to go do the arm. So you can see it on here too if you're really curious. It's going to just go supply the arm on both sides, and then it does the head and neck up here, which you don't really have to worry about. Okay. And then the descending aorta is the rest of the body. Here's the descending aorta. So really all you really need, the descending aorta branches are implicated more so in GI. GI anatomy is a lot of blood supply as well. Like, isn't just every block? Yeah, a lot of blood supply moving forward now. We had it easy with pulm. But for cardio, at least knowing the locations of these major branches off of the abdominal aorta are good enough. So I highlighted the ones that I think you should know. So the celiac is at the level of T12, the SMA is at the level of L1, the renal arteries, where, cardiorenal, these would be good to know. These are at around the level of L2. The gonadal arteries, which are for, to supply like the gonads, which is a repro thing, but that's between L2 and L3. The IMA is located at L3, and then the bifurcation of the abdominal aorta occurs at L4, and people remember that with bifurcation. And then you have the right common iliac, the left common iliac, and then these bifurcate as well, and that's going to be at L5. All right, but the reason I'm talking about this thing is because there's another path tie-in here with where aortic aneurysms occur. So we're going to talk about aortic aneurysms. I forget where I put them. I think I moved them back a little bit. But aortic aneurysms, I'll give you a little quick, like, what is an aneurysm even? But usually abdominal aortic aneurysms, aka AAAs, they occur in between the renal arteries, so around the level of L2, and between the bifurcation of the aorta around L4. So that's just like hey, where do abdominal aneurysms occur normally? Or aortic aneurysms, where do these normally occur? You're like, all right, between the renal artery and the bifurcation, aka between L2 and L4. This is just from that PowerPoint, so you can see like branches off of the aorta and the levels of like basically where they are. So here's a AAA. So AAA is abdominal aortic aneurysm. So very briefly, we got the question yesterday about what is an aneurysm basically. And an aneurysm is basically when like the wall, so remember we have actually, let me go back to the 3 layers, that might help. So we have all 3 layers here of like this blood vessel. And with an aneurysm, what happens is usually it's because something is wrong with the connective tissue layer. Like I said, it's like a Marfan's or Ehlers-Danlos syndrome. You guys know what I mean. Usually it's like some sort of connective tissue disorder. So like this is like really not doing what it should be doing. It's not strong. It's not that strong. It's not really holding this artery together. And an aneurysm is basically when the blood that's in here in the lumen can push out against the wall, and now this artery just bulges. Like it just bulges more. It's like it's a little bit more compliant than it should be because something's wrong with like the connective tissue. So usually with abdominal aortic aneurysms, normally the abdominal aorta should look like this. It should look like a nice tube, nice and non-compliant. It's not going to do what the blood in there is telling it to do. But with aneurysms, the blood in here can kind of push out on the walls, and the walls are going to let it do it because like something's wrong with that connective tissue. And then it's going to kind of look like a little bulge. And that's an aneurysm. And you can see aneurysms in like neuro, because remember, like you can get like neuroaneurysms. It's the same thing. The blood vessels just kind of like undergo an aneurysm. They kind of dilate more than they should. So a localized dilatation, and again, usually it happens between the renal arteries at L2 and the bifurcation of the abdominal aorta at L4. Okay. And then I took out the other points that I didn't think you really needed to know right now. That can be like more of a second year thing. This can rupture. So if an abdominal aorta ruptures, because again, just too much blood pools here and it goes pop like a balloon, not great, not ideal. But it can pop, and then where the patient is going to feel the pain is going to be in the back. And the reason why is in another anatomy thing we're going to talk about later. The abdominal aorta is a retroperitoneal structure, meaning it's going to be more so towards the back. So a lot of the times they'll mention that they have like this severe back pain or like this severe abdominal back pain, like lower back pain. Okay. And then here's a cadaver picture of the abdominal aorta. It should not look this dilated. So this is clearly, they're not doing too hot, this person. Next is coarctation of the aorta. I didn't really know where to throw this in, but it's an aortic pathology state, so I wanted to talk about it. So coarctation, another name of this really is just like stenosis, which again is like a very narrowing. But coarctation is like narrowing to the point of nearly blocking. It's not really just stenotic, it's like closed almost. So that doesn't sound great, right? Like to close off the aorta, you're like, oh no. So basically it happens in children. There's this term preductal, postductal. We're going to talk about the ductus arteriosus with embryo. In children, usually coarctations, if not usually all the time, coarctations are going to be before the ductus arteriosus. And in adults, it's going to be after, where the ductus arteriosus remnant is. It's called the ligamentum arteriosum, but they just call it preductal, postductal, just to keep it consistent. Characters, I mean, just imagine, before I even mention this characteristically, just imagine what would happen if you do not have, blood going up to like the head and neck area, but you still have blood kind of going to like the rest of the body. You're going to see increase in blood pressure in the arms and legs, and then a decreased blood pressure in the legs, and maybe it'll help when you see a picture of it. But another thing that they can say is, oh, there's a brachial femoral delay. So it's kind of like the brachial arm blood pressures and the femoral blood pressures don't line up. There's a delay in blood pressure there. Other things you can see are certain things on chest x-ray. We'll talk about those. And then just kind of like making associations, like genetic associations, which you'll learn about more so in repro, is Turner syndrome, which is like a genetic disorder, is always usually associated with coarctation. So it's like a good buzzword to kind of look out for in questions, as well as a bicuspid aortic valve. So remember, aortic valves, these are semilunar valves, so there should be 3 cusps. But if you have a bicuspid aortic valve, you only have 2 cusps. So now you have 2 cusps doing the work of 3, and you can imagine that the aorta gets upset and then it undergoes coarctation. It doesn't happen like that, but still, like, just imagine it's like you have 2 cusps doing the work of 3, so you can imagine there's going to be some sort of pathology state associated with that. So this is the preductal versus postductal. So again, we're going to talk about the ductus arteriosus for embryo, but with the ductus arteriosus, it is like this like branch that comes off of the pulmonary artery. It allows for normal fetal circulation in children, not in children, in the developing fetus. So preductal coarctation means this very, very bad stenosis happens before where the ductus arteriosus would be. Postductal would be in adults. It means that, and again, it's not the ductus arteriosus anymore, it's the ligamentum arteriosum. Once it's like it kind of goes away and it turns into the ligamentum arteriosum. But they still call it postductal because it's still after the ductus arteriosus. But a lot of the times they'll try and tie in anatomy again. It'll be like, oh, like in kids, they won't say it's preductal, postductal. They'll be like, in kids, it's after the left subclavian, but before the ductus arteriosus. Or this one would be like after the left subclavian and after the ligamentum arteriosum. So just kind of, again, keep in mind like where all this is happening. The ductus arteriosus joins with the aorta, normally like in fetal circulation, after all of the arches. So this is rib notching. So rib notching is something that you can just see. So again, you have this really bad coarctation. No blood can basically get to the rest of the aorta, and the body starts to freak out, and it basically makes like backwards blood flow through some of the internal thoracic and intercostal arteries, which you can kind of see here. So imagine there's a coarctation like here, I guess. So this would be like a coarctation in this image, and everything just starts to like backflow through arteries. It's trying to like go around it almost. So it kind of goes through the internal thoracic and intercostal arteries. There's also collaterals that kind of form around it so that it can still kind of like get blood to the rest of the body. So you can also see on here that there's collaterals everywhere that kind of just pop up out of nowhere. So remember, collaterals and anastomoses are not the same. These collaterals are like new vessels that are kind of forming. Again, so here's kind of like a coarctation, and then you can see like the intercostal arteries have like not notching, but they kind of get all like squiggly and stuff. And on chest x-ray, it's going to present as rib notching. So instead of looking nice and straight, like the ribs looking nice and straight like this, where those arteries are on ribs are going to kind of make it start to look like bumpy. So it says like, oh, these ribs are notched. It's really hard to see on chest x-ray. Like I'm like, all right, yeah, I guess they're not totally straight. But a lot of the times you're not going to just use chest x-ray to diagnose this. There's also usually the number 3 sign that you can see. It's like this hourglass-like narrowing of the aorta. This is the coarctation. So remember from when we did the cardiac shadow, this is the aorta, and then down here would be the pulmonary artery. Now we have this kind of coarctation, this narrowing, and it makes it look like a number 3 sign. Aptly named. All right. And then, so now veins in the body. So remember, every artery has a corresponding vein, but what I want you to notice almost immediately is that the superior and inferior vena cavas are on the right side, basically on the right side of the heart, because the arterial system has to be over here on the left side, so it needs room for it. So veins run along with the corresponding artery. So again, the blood flow is going down. The venous system, at least from the lower half of the body, would be going up. The major veins to know, IVC, SVC, what are they draining? So the IVC is draining all of the lower body. The SVC is draining all of the upper body, and the head and neck, those areas. There are the difference between like superficial veins versus deeper veins. Superficial veins are ones super close to the surface. So the saphenous vein is a good example of this. You can kind of see, like, it even looks on this image like it's close to like the surface of this leg. Deeper veins are like closer to like the actual bones of the body, so like the long bones. So like, for example, here's like your femoral vein and your even deep femoral vein. Like these are deep veins. And they're relevant for like deep venous thromboses, when like you can get a thrombosis, like a clot in a vein, and then it can, go back to the heart. But regardless, we have, but deep venous thrombosis is usually in these deep veins. So like your iliac vein, your femoral vein, popliteal, tibial, just as some examples. And usually they're in the legs, because they're the furthest away from the heart. So it's the longest amount of time to allow like blood to start pooling and clotting. So from the lower body, veins drain up. They're returning back to the heart. And remember, they're draining into the right atrium. From the head and neck, these veins are draining down, and they're draining into the right atrium from the superior vena cava. And this is important to understand for pathology states. And remember when we talked about cardiac tamponade, why we see jugular venous distension? This is kind of why. So in something like SVC syndrome, where usually it's caused by a Pancoast tumor, it doesn't have to only be a Pancoast tumor, it's just something that's compressing on the superior vena cava, you get symptoms that are just basically blocking venous blood flow. That's all the symptoms are. So just imagine blocking the superior vena cava, which is draining blood from the arms, from the neck. Now it can't get to the right atrium. It backs up. It just all backs up. And that's where you get the jugular venous distension. That's where you can get edema. So they say like, oh, there's facial and upper arm edema, as well as like JVD and like chest distension. That's why. It's just blood's there, because it doesn't have anywhere to go. So it just backs up. Okay, so that's SVC syndrome. Same thing also applies for cardiac tamponade, when the heart's not really pumping well. So like the SVC can drain it all at once, but now the heart's not really pumping well, so blood kind of stays there, so it just all starts backing up. It's kind of like what happens with heart failure. But with Beck's triad, it like goes back up into like the superior veins, like the superior vena cava, and that's where you see the jugular venous distension. Next, I want to talk about the azygous venous system, because there's an anatomy tie-in that you need to know, and I just wanted to briefly mention what the azygous veins were. So there is this other venous system that kind of parallels with the in the IVC and the SVC. So the azygous venous system is another series of veins that still drain into the SVC. But you can see here, there's an azygous and then an hemiazygous. So let me just go. So that I'm talking about these veins here. And again, these are going to drain upwards. So they're going up. This is the hemiazygous in green. And they kind of join in with the azygous. And then the azygous is making its way up into the superior vena cava. And then it can drain into the right atrium. So the azygous vein is the one on the right side. So I have this picture here for reference. So it's the one kind of going up like this to drain into the SVC. It passes through the diaphragm. So this is kind of why I wanted to mention it, and we'll talk about this in a second. It drains into the SVC, and then it has tributaries, which is kind of like, tributaries are like these veins drain into it. It's kind of like lakes. So like these lakes are tributaries of this other lake. So we have the hemiazygous, which is on the left side here. So here's your hemiazygous. Remember, it was the one in green on the last slide. It dumps its blood into the azygous vein, as well as the accessory hemiazygous vein, which is here, and it dumps its blood into the azygous vein as well. So those are the two main tributaries, but at the end of the day, it all drains into the right superior vena cava. So this crossing over happens, and it gets into the right superior vena cava. So it is important to know these because of you have to know the structures that pass through the diaphragm. I had a question on boards about this. You'll probably get it on your exam. It's just like a classic anatomy question. So the diaphragm has structures and they pass through at different thoracic levels. So the mnemonic that people use is I ate 10 vegan eggs at almost 12. So I ate is the inferior vena cava, passes at the level of T8. 10 vegan eggs, the vagus nerve as well as the esophagus pass through at T10. At almost 12 is the azygos vein, the thoracic duct, and then the abdominal aorta at T12. So here's just showing the aorta. People also can remember what happens at T12, like what 3 things are included in T12. At T1, 2, it's the red, white, and blue. So the abdominal aorta goes through here, the thoracic duct goes through here, and then the azygos vein goes through there. Kind of another path tie-in is thoracic outlet syndrome. So thoracic outlet syndrome, you'll learn about this with OMM. This is like a very musculoskeletal. You actually cover this again in neuro probably. It's a very musculoskeletal like issue. And basically the symptoms are caused by compressing the structures. So if you understand the structures that are getting compressed, you can make sense of the symptoms. So there's 4 main things that get compressed in thoracic outlet syndrome. And if you kind of zoom in on the thoracic outlet, another name for the thoracic outlet is the anatomic thoracic inlet. I have no idea why, but if you see that, it's the same thing. The brachial plexus is in here, and the brachial plexus you'll cover in lots of detail in neuro MSK block. This is your supplying all the nerve supply to your upper arms, basically. So this is, if you were to compress it, you would block that nerve supply, and you would get pain and tingling in like the upper arm on whatever side the thoracic outlet syndrome is on. The scalenes are also located here, so that's muscles. The scalene muscles, you'll learn about these in OMM. If you haven't done rib stuff yet, you'll eventually do rib stuff in OMM, and then you're gonna be talking about the scalenes a lot. When you compress the scalenes, they can become really tight, and then you can have neck pain here. And then the 2 that are relevant for this block are your subclavian arteries and veins. We talked about the subclavians. Those are on the left side, at least, it's a branch off the aorta. Right subclavian is a branch off of the brachiocephalic trunk. But it's an artery and a vein. So if you block an artery, you're not bringing blood to the arm. That's going to manifest as loss of blood to the upper arm. It's going to be painful. It's going to also feel a little tingly, like stuff like that. The subclavian vein, if you block a vein, just like we talked about SVC syndrome with Beck's triad for cardiac tamponade, you're going to get swelling, you're going to get venous distension, you're going to get all sorts of stuff. So, because again, if you can't, and like imagine there's here's where the subclavian vein comes in, you can't drain this blood now because it's compressed, so it kind of backs up, and that's why you can see like arm swelling. But another kind of anatomy plug that I had mentioned during the live session is if they show you a cadaver image, right? Like they show you a cadaver image and they want you to be like, all right, which one of these 2 structures, the artery or the vein, which one of these 2, point to it on like which letter, for example, is the one that's going to cause like swelling of the arm. And you're like, oh my God, because in cadaver images, they're not color-coded red and blue. And this is just a rule of thumb moving forward. Anytime you see an artery and vein coupled together, and you can even go back and fact check me with the other images in this PowerPoint, veins are always in front of the arteries, always. And if you think about it, makes sense. Veins, super compliant. So if they need to, they can kind of like expand. It's not going to hurt anyone. Arteries are thick vessels. They are not moving. So if something if blood pressure increases, it's going to stay strong, but it can push on the vein. And if it pushes on the vein's like, sure, we're doing this. I'm compliant. I'll do whatever you tell me to do. So if the vein gets compressed, you can get like edema, distension of everything before it and whatever. So usually when you see like pairs like this, the vein is always in front of the artery. So I don't really have a picture. I wish I almost had a cadaver picture of that. But just again, if they show you like 2 random arteries, one's an artery, one's a vein, they tell you, and you're like, okay, which one's which? Vein's always in front of the artery. But here's just more cadaver pictures of the aortic branches. So again, if they were to ask you like, what's this, hopefully you know. Here's another view of it. This, you don't even have to know what vein this is, but it's just kind of proving to my point again. I think this is like the left brachiocephalic vein, I think. really have no idea, but that's what it seems like it would be. But notice that it's over top of the arteries, and that's usually just anatomically how veins are. It's always going to be on top of arteries. Here are cadaver images showing venous drainage and also the arteries themselves. But so it's showing in here, this is like the artery, like the actual arteries, like the coronary arteries we talked about, and then I put which veins are lining up with it. And then kind of the same thing here. Oh, here's kind of like, okay, cool. So see how this is like the arteries here? So the brachiocephalic artery, left subclavian artery, left common carotid artery. I don't even know what direction this is going. Oh, so this is the head's up here. Here's the heart. That didn't help. H and H, heart and head. So it's kind of like the blood's going this way. It's draining this way into the heart, and arteries are going this way. But regardless, the vein is in front of the artery. The superior vena cava and its branches, like the brachiocephalic vein, probably on both sides. Oh, that probably was the brachiocephalic vein. All right, anyway, that is draining into the superior vena cava. It's over top of the arteries that are also located there. All right. Evolution of an MI. So this is going to be more anatomy and histology. So this is something good to know, not only first year, but also second year, but they ask about it first year because of the tie-in with anatomy and histo. So evolution of an MI, a myocardial infarction, and a heart attack, the tissue itself changes over time. And it's basically, and I'm just going to go to my slide, but every source is going to say something different. This is kind of like what first aid says, so this is what I went off of. But just keep in mind, it does change source to source. They're not, if you're worried about questions, like they're probably, like the people that write questions know that sources kind of differ a little bit in terms of like the exact days. So it's more so just understanding in general, like the rough time period is going to be fine for you. So here's an overview, and the reason they make these like numbers, there's 6 like time points that they mention after a heart attack, is because this is probably where you're seeing some changes to the actual histology of the heart. So less than 30 minutes after an MI, then it goes from 30 to 24 hours, then 1 to 3 days, 3 to 7 days, 7 to 14 days, and then 2 weeks to several months. What this process is actually showing, and just something to keep in mind, what I was about to mention on the last time, is you have to think about basically what a heart attack is you're losing blood. If you lose blood, you have no oxygen. If you have no oxygen, the tissue dies, necrosis. So necrosis usually is the first thing that happens when you lose blood and the tissue dies. Then you're going to have an inflammatory process that occurs. So I'm going to give you a little bit of immuno. We're going to cover tons of immuno at the end of the year, and it's going to be great. But I'm going to give you just a little bit of immuno because you do have to kind of know it, because it's like an indicative of like these processes. It's like certain type of immune cells are indicative 1 to 3 days versus 14 days. And then after you have inflammation, you start to have repair, because like you can repair it. You're not going to be able, it's necrotic, which means it's dead. You can't bring the tissue back to life, but you can at least have like a scar that can form. And like just like when you cut yourself outside, you can get a scar that forms. And then just like a fun fact, a path tie-in is the most common cause of death following an MI is an arrhythmia. A lot of the times that's asked, which people I don't think about. I think they think you get an MI and it's like they die because like that part of the heart is not getting oxygen, and then that part of the heart can't pump blood, and then they die because they can't get blood. That would happen eventually, but before that could even happen, the heart freaks out and it goes into like this random rhythm, and that usually kills the patient. Usually it's a ventricular tachycardia or something, and that kills the patient. So that's the most common cause of death following an MI. So that could happen at any point within this process. So this is like someone that would not die from an MI. This is the process that they would go through. So the first thing is less than 30 minutes post-MI. So like let's say the person had a myocardial infarction, they lost blood supply. Up to 30 minutes of losing blood supply, you have a reversible injury, which is cool, right? You're like, wow, like I lost blood supply, but if I kind of get the blood back to that area within 30 minutes, it's going to be fine. I can reverse the injury. A lot of the times this doesn't happen because you need to like catheterize the patient, and that doesn't take 30 minutes. But if it were in theory to happen, you could reverse it. So this is a picture from first aid. This is like certain things that you can tell that happened. Pathoma for second year, when you guys do pathoma, which is like really intense path, he goes into this way more detail, so you don't need to know it in that extent right now, but just basically understand a normal cell, when it experiences loss of oxygen for up to 30 minutes, this is what happens to the cell. It swells, it undergoes like membrane blebbing, like all sorts of things happen. But I think swelling and this membrane blebbing are like two characteristic features that if they say in a vignette, you know you're in that reversible injury part. You're like, oh, we're only 30 minutes after an MI, we're good. Let's cath them, let's get them back to normal. And the reason why you get swelling is because we lose ATP, because again, no oxygen, no ATP, can't do anything. And what's like one of the most important pumps in the heart is the NAK pump. So if the NAK pump can't pump, it's just the water follows salt, the heart just kind of swells. Like all the cells individually just kind of swell because it follows the salt, and that's why you get swelling, and also membrane blebbing. So now we are in the irreversible injury. So unfortunately, if you do not cure someone of an MI within 30 minutes, now we become irreversible injury. So now we start that process. So this irreversible injury, this is your necrosis. And again, I'm just kind of keeping this up here through the entire time to remind you guys, like there's necrosis, then inflammation, then repair. This 30 minutes to 24 hours after an MI is the necrosis, like the dying off of the cells. So we have irreversible injury, and there's a few characteristic features like histologically that you look for. So the first thing is called mottling. So mottling is basically like, you can see here, it's kind of like there's these irregular marks, there's spots, there's streaks. It just looks very splotchy. That's mottling. Then they'll usually say something like there's a tetrazolium stain, so a TTC. Tetrazolium stain stains uninfarcted tissue. So I'll show you a picture of what the tetrazolium stain looks like. You can just pick out where the tissue is that like died versus the nice normal tissue. At this point, since we have true necrosis, like those cells are dead, they're dying, they're just bursting open and dying, those cell contents can just leak out into the blood because now they're just kind of like exploding open. And this can lead to edema, hemorrhage, and what's known as wavy fibers. So wavy fibers, so here would be the normal. This would be like the normal cardiac like histology fibers. They look like this. And then when you undergo, sorry, I did that backwards. This is the normal cardiac fibers in the lighter pink. And then the ones that have died and are now splitting open and releasing its contents, you can tell because the nucleus looks like it's like degraded. It's split open its contents, releasing all of its stuff out into the body. You can see them here. It's just kind of like all there. This is what's known as coagulation necrosis. And again, you're going to go into a lot more detail second year with what the different types of necroses. But coagulation necrosis is the first thing that you see in post-MI for that irreversible injury. First cells that are on the scene, first immune cells, neutrophils. So neutrophils come on the scene. Neutrophils just like to gobble everything up. So they kind of come, they're like, oh, like, look, there's fresh necrotic cell contents. I'm going to gobble that up. So neutrophils arrive within this first 24 hours. And then you can also get reperfusion injury at this time. So again, if you catch an MI at this time and you cath them and allow blood flow to now return, so here's the occluded artery. If you unblock it and take it out of the way and allow now these arteries to now get reperfused with blood, oxygen's great, but it likes to make a lot of free radicals. And if it happens too quickly, like in reperfusion, the blood's gonna pour in. The oxygen can actually damage the area. So a lot of the times when you see reperfusion injury, a lot of the times people call that reoxygenation injury because oxygen just makes all these free radicals, it freaks out, and it just causes more damage. So this is a tetrazolium chloride stain, so a TTC. And remember, TTC stains uninfarcted tissue. So this would be uninfarcted, would be this dark red. So everything that was not stained, that was the infarct. And this is just like a cross-section of the heart. This is the left ventricle. Here's another infarct with this TTC stain. So here's coagulation necrosis. What you can look for is like this. So I put this on here. Look for contraction band necrosis. So again, like I said, this is the earliest change seen histologically. So here's your normal cardiac muscle. Here's kind of like the normal bands that you see, the normal fibers that connect each of the cardiac cells to each other. When you have coagulation necrosis, they can look very wavy. So they can look nice and like wavy like this. And it doesn't matter where you look, they all look wavy. Those are called wavy contraction bands. This is like contraction band necrosis. Here's more wavy fibers. So again, here's your muscle fibers, your normal muscle fibers. It can straight up look this bad. So not only can like the striations themselves kind of look like very wavy and undergo that contraction band necrosis, but then the fibers themselves can look very wavy. All right, so then 1 to 3 days post-MI, now we're in that inflammatory area. So all the necrosis is done, all the cells split open that we're gonna die from not having oxygen. And now the things that happen here are hyperemia, so increased blood flow. And this can be from collateral blood supply. This can be from, some of the neutrophils gobbling some stuff up, allowing for more blood supply to form there. Inflammation is occurring here. And with this 1 to 3 days post-injury, the pathology state that you can see here is called ventricular free wall rupture. So now this ventricle can just rupture open, and it's because there's neutrophils here gobbling away. So maybe they're gobbling up too much tissue, more tissue than they should. It can make the wall really weak, and then it can just literally rupture. And when that happens, it can actually lead to cardiac tamponade. And I'm saying all of this, trying to tie in all this path, because a lot of the times it'll say like a patient comes in with like cardiac tamponade, and then it's like, oh, they had an MI like 2 days ago. You're like, oh my God, ventricular free wall rupture. Like that's the underlying basis of their tamponade. So you can see here, this is now, it just looks like it's getting worse now. So here's the normal up here. Here's the infarcted tissue, extensive coagulation necrosis. It's still just kind of like falling away. And we have this acute inflammation. We have these neutrophils on scene. So here's like these purple cells. These are neutrophils. This looks like a smiley face, but it's a neutrophil. All right. So here's ventricular free wall rupture. This is another good anatomy thing to be able to tell. So if they ever show you a heart like this, which you probably will see soon, usually it looks like, a circle on one side and then like a little triangle looking thing on the other side. It's again a transverse section. Remember we did a transverse section and you were looking up onto like the valves, so the mitral valve, tricuspid, and the aortic pulmonic. This is a transverse section, but now we're looking down at the heart. So we remove the valves and everything. Now we're looking at what's left. So the left ventricle, like I said, look for wall thickness. The left ventricle is always going to be the thicker wall. So that's going to be here. And then the right ventricle is going to be a lot thinner here. And then they're separated by the interventricular septum. So this is a normal heart. So you can see ventricular free wall rupture is literally where the ventricle just ruptures open, which can lead to cardiac tamponade, which is what this is showing here. So you can see in the pericardial cavity, this fills up with blood, and that's your tamponade. All right, so now 3 to 14 days post-MI. So anywhere, like inflammation lasts from anywhere to like 7 days-ish, like 7 to 10 days-ish, and then the repair process starts to occur, like 10 to 14 days-ish. So at this point, 3 to 14 days, we're in both like inflammation and the beginning of repairs happening. Still irreversible, but now we have even more hyperemia. We have even more kind of blood coming. Macrophages appear. So macrophages are going to be those types of cells that are going to gobble, like they're going to start repairing. So they're gobbling up now the neutrophils that were there. They're like, all right, you guys are done. Bye. Like our turn. Macrophages are very, very good at repairing things. So one of the things that they can do is set down what's known as granulation tissue. And granulation tissue is basically the beginnings of a scar. So here we are, here's your infarct. So these tiny baby cells, these are the neutrophils that are like just causing all sorts of inflammation. These bigger cells, these are your macrophages. So now macrophages start to arrive on scene. They try to eat up the neutrophils. They're trying to now repair. They're laying down granulation tissue and yada, yada, yada. So at this point, you can still have free wall rupture that leads to tamponade. Other things that you can see is papillary muscle rupture. So remember papillary muscles we talked about that are connected to the chordae tendineae? The papillary muscles can rupture. That can release leaflets like of the valves, and you can get murmurs. So the most classic murmur that happens after an MI is mitral regurgitation. So you can see how they tie this into like pathology like a murmur. Your interventricular septum can rupture, again, due to macrophages. The macrophages themselves, they're just trying to put down granulation tissue. They just do too much sometimes, which can like annoy the septum, and then it can just rupture. You can also see a left ventricular pseudoaneurysm. I'll show you what a pseudoaneurysm looks like. But basically, here's granulation tissue. It's like rebuilding after injury. So like I said, macrophages are involved. So macrophages are usually involved. They're helping put down like this granulation tissue, but also fibroblasts are involved. And fibroblasts are trying to lay the foundation for a new extracellular matrix. You're trying to repair basically injury. So they're kind of playing a role in this. After the granulation tissue is down and everything's good, that's when the epithelial cells, which you can kind of start seeing, are forming. The epithelial cells will start to form over it, and that's your scar. So that process is known as epithelialization. So this is a pseudoaneurysm. Remember how I talked about an aneurysm was kind of like when you have this and then you have like a true bulge, so all three layers are kind of going to get bulged out. A pseudoaneurysm is when not all three layers are bulging out. You're still getting like an aneurysm-like thing. That's why it's pseudo. It's like, oh, it looks like an aneurysm, but it's not a true aneurysm because it's not all three layers. So usually it's like this, and then usually it's going to look like a portion of it is going to like have this like weird looking aneurysm looking thing. That's a pseudoaneurysm. So you can see that 3 to 14 days after an MI. Then 2 weeks to several months after an MI, now we are straight up in repair. Repair, like I said, happens anywhere from like 10 to 14 days after, and we're still repairing it up until several months after. So think just like granulation tissue, think scar, think just repair has occurred. But what they get you with on here is the complications that can happen from repair. So the first thing that can happen is called Dressler syndrome. This is an immunology thing, but I'm going to explain it to you. If I had to guess, they love to ask about Dressler syndrome. I think because it's like immunology in cardio, and they're like, oh my God, we love immunology. The test writers, not me. I also love immunology. But heart failure can occur here. Here's where you get that fatal arrhythmia that can occur. That's usually happens during this phase, which you're like, well, that sucks. Like that kind of, it's repaired and you can still get an arrhythmia. You can also see a true ventricular aneurysm here, and I'll show you like what this, like why do you get a risk of like thrombosis, I'll kind of show you. But again, with this, kind of think scarring, like it's repaired, but all these complications can occur. Oh, I lied. It's not the, Dressler syndrome is not the next slide, but I think it's the next slide after this. So a true ventricular aneurysm, like I said, all three walls are going to be now like kind of like bulging or dilating out. Don't worry about the EKG right now. We're just doing anatomy. So all three walls, all three layers bulge out versus a pseudoaneurysm, which is not all three layers. But since it kind of looks like this little outpouch, it kind of looks like another, like just, it kind of looks like another appendage that doesn't need to be there. So what can happen is you can get thrombi that form here. So thrombic clots, just like the atrial appendages, you can get clots that form here. And then the heart can just send it out to the rest of the body. So I like this picture because it shows all the different areas that you can get thrombi, and it's just mural thrombi, means that it attaches to like the wall of like a blood vessel, but hopefully that makes sense because it's going to be anything that the left ventricle sends blood to. So all of these areas can potentially get mural thrombi because it can just get blood sent to it, because the clot can form in this aneurysm and then it can be sent to the rest of the body. All right, so Dressler syndrome, no one really knows what what causes Dressler syndrome. My personal theory, and I have my master's in immunology, right? So I can talk to this. But my personal theory is that after you have an MI, we talked about how all the necrotic cells kind of burst open, and now it's like all these like random things are in the blood that shouldn't be there. The immune system is like, that's weird, I've never seen these before, like, and it thinks that they're antigens or like foreign materials, and now it's like, oh my God, we have to attack this. This is a virus that we've never seen before. We have to attack it. So they don't know what's happening. That's what I think happens. It makes total sense because now the immune cells try to get to the heart, and the first layer they encounter is the pericardium. And basically, Dressler syndrome is autoimmune mediated pericarditis. So here's your normal pericardium, here's your pericarditis. It would look kind of similar to the pericarditis I showed you earlier. The positional chest pain would happen, the diffuse ST elevations would happen, but you want to stop any anticoagulant therapy that you're on at this point if the patient is presenting with Dressler syndrome. So here's a question that I wrote, just trying to show you the typical way that they would ask about this using histology, pathology, all this stuff. So without using biomarkers or an EKG, can you tell basically with these anatomical and histological changes approximately when this patient had an MI? So you can pause the video if you guys are doing this on your own, but we're going to talk about how the anatomic changes, the heart tissue shows macrophage infiltration, granulation tissue, and a left ventricular pseudoaneurysm. So right off the bat, like I said, granulation tissue, you're like, oh, when does that start to set? That starts to set when, there's repair kind of starting to happen. So not only that, on physical exam, we have some sort of murmur, which I know we didn't do murmurs yet, but it's loudest at the apex. This is basically describing a certain murmur by giving you how it sounds when you listen to it, as well as the location of the sound, as well as any maneuvers that can help you figure out which murmur this is. So if you pause the video to kind of answer this, but we're going to keep going. So this is basically showing your 3 to 14 days ago. So we have repair starting to happen, but we're not in that true repair stage yet. We don't really have like a true scar, and it's kind of emphasized with the pseudoaneurysm. Like we don't have a scar, so there's kind of like the blood can kind of seep through some of the layers and make like this pseudoaneurysm, as well as you can have papillary muscle rupture, which can lead to a mitral regurgitation murmur, which is what they're describing here basically. Okay, so that was all the stuff that I had added to the anatomy section. Next, we're going to do cardiac embryo, and I'm going to start, just like how I said in the live section, I added a lot more embryo slides that we don't need, well, you guys don't need for first year. I will tell you exactly what you need to know for first year. It's more so for the people that are interested in taking STEP. STEP heavily tests embryo. I don't know if anyone is aware, but Comlex does not test embryo. That's why embryo is not in anyone's curriculum for any DO medical school that you're at. But being PBL, you have the opportunity to study embryo. You can just add it to your curriculum if you want, which I highly recommend because they can still ask path questions in the context of embryo. But for example, for your exam questions, for example, they're not allowed to write exam questions asking true embryo. So they're never going to go into this level of detail, but they can ask embryo in the context of these pathology states. Okay, so that's my little disclaimer. So the first thing is fetal circulation, and fetal circulation is really important to understand because it's kind of like going against everything I just kind of taught you about blood flow. So the reason why is because in the developing fetus, it doesn't have lungs that are functional. So the lungs can't oxygenate the blood. The oxygenation of the blood is coming from mom's placenta. So that's kind of where the oxygenation is occurring. So it's still the same construct. Veins go to the heart, arteries leave the heart. So we have this umbilical vein, this umbilical artery. So the umbilical vein is still going towards the heart and the umbilical arteries are going away from the heart. But if you notice, the oxygenation is reversed. So this is kind of like a fun, not fun, but like an anatomy thing. They're like, oh, the vein is oxygenated. Haha, let me trick everyone. But you just have to remember that. The placenta is the oxygen. So the umbilical vein, which is now leaving the placenta, going to the heart, has oxygen. And the whole point of this now is like, think of the placenta as the lungs. It's trying to basically give blood to the give oxygen to all the developing organs because all the developing organs need oxygen. The lungs still need oxygen. They need oxygen to grow properly. So that's what's happening here. So the oxygenated blood is going through the umbilical vein. It kind of like, it sends like a little branch off. It swerves. It's like, here you go, liver, take the blood. But it undergoes a shunt. It shunts some of the blood that goes to the liver into the inferior vena cava through a shunt known as the ductus venosus. So you can see the oxygenation it drops off a little bit because we have the inferior vena cava, which is totally deoxygenated blood. And now we have some high oxygen mixing with it. So now we have moderate oxygen. Comes in through the right atrium, and now there's a second shunt that it goes through. And this is what I was mentioning earlier. Remember the fossa ovalis that you can see in between the right and left atria? Now you have the foramen ovale in utero. It's called the foramen ovale, this oval-shaped foramen or hole. And it just basically allows the blood, this oxygenated blood from the right atria, to go directly across to the left atria. So all the blood goes directly across it. Because again, we need to bring oxygenated blood to the rest of the body. So we don't want to not have oxygenated blood for it. So we're we need to get this to the systemic circulation. So this is an example of a right to left shunt. Because it's going from the right side of the body to the left. Well, the right side of the heart to the left side of the heart. or like the pulmonary-ish circulation to the systemic circulation. So shunts through, now it goes through the aorta. So now we're back into we're still at our moderate oxygenation of blood. And then it's joined by this pulmonary system. So to understand why it switches from moderate to low oxygen, we kind of have to look back into the right atrium. Notice that the superior vena cava, which is deoxygenated blood, is still bringing blood to the right atrium. So this blood, you can follow these blue arrows. It's like low oxygen at this point because it's mixing with this moderate oxygen. This moderate oxygenated blood coming from the inferior vena cava is mixing with this very low oxygenated blood coming from the superior vena cava, and we have moderate. We have moderate oxygenated blood going straight across, and we have low oxygenated blood that basically is coming straight from the superior vena cava. It just continues downwards. All right, so before this inferior vena cava blood, it's shooting up, so it goes straight across through the foramen ovale. This deoxygenated blood from the superior vena cava comes in, shoots down, just keeps going, shoots down. So this is that low oxygenated blood, and now it's going through the pulmonary artery. And you're like, well, why are we going to the pulmonary circulation? The lungs aren't working. The lungs still need oxygen to grow. Doesn't matter if it's low oxygen, it needs just a little bit of oxygen in order to properly grow. So that's the point of it. It's trying to bring oxygenated blood, even if it's low oxygenated blood, to the right and left lungs. But here's your third shunt. So here's your ductus arteriosus. This is now shunting back to systemic circulation, so another right to left shunt. This is shunting back through here into the aorta, and now we have moderate oxygen mixing with low oxygen, which just kind of keeps it at low oxygen, which is fine. And then this is sending the low oxygen basically through the abdominal aorta to all those other organs. And again, it doesn't matter, it's low oxygen, it's fine. Okay? But that's why, and then it returns to the placenta to get reoxygenated via the umbilical arteries. So it's just kind of like a little flip. The umbilical vein has oxygenated blood, umbilical arteries has deoxygenated blood. Okay? Fetal circulation. All right, so more on it now that we just kind of talked about it a little bit. The reason why this all happens is the fetus has hemoglobin F. Hemoglobin F loves oxygen, does not want to get rid of it. So it's basically stealing oxygen from mom's placenta. That's how it's getting oxygenated blood. The fetal lungs are fluid filled. We have absolute global hypoxic vasoconstriction happening, so they can't oxygenate, but again, they still need blood. And again, in the fetal system, the right side, like the right-sided pressure is a lot higher than the left-sided pressure. And again, it's because it's basically all this is happening from the right side. And again, that's because the oxygenated blood is coming from the right side. It's going into the right atrium, and then the right atrium is shooting it across to the left side. And then you do need to be familiar with these three main shunts. So the first shunt, like we talked about, the ductus venosus, it's shunt 1. The reason this shunt exists is because the liver, if it had its way all the time, it would take all of this oxygen from mom and be like, cool, give it to me. Liver loves oxygen, absolutely loves it. So it needs to shunt some away into the inferior vena cava rather than just doing it itself. Because if it just did it itself, if it went after the liver would be like, nope, sorry, I got no oxygen left for you. So it just needs to do this shunt. So it brings some to the liver, but then it's like, all right, whatever, here, take this amount, we're bringing the rest to the heart. This is also the second shunt to close after the fetus is born. The foramen ovale, this is your shunt 2. We've talked about this. This is the shunt that allows for the right atria blood to go to the left atria, so it's a right to left shunt. But again, notice that some blood is still getting to the right ventricle. Again, we've talked about this already. Most of the blood is getting shunted to the foramen ovale. The foramen ovale is the first to close when the fetus is born. This is a very embryological tie-in. It's a concept known as the first breath. So when the fetus is born, now it takes its very first breath. So the baby takes its first breath. It's such a high pressure now in the left side, because now it's everything switches. It's like, all right, we're like actual people now. Everything needs to go away. The lungs are working. So it takes its first breath for the lungs. It's so much pressure that it shuts this flap in between the left and right atria. You can see this flap here. And we'll talk about it a little bit with the embryo, but it just shuts it and it keeps it shut. That's how high the pressure the system is. And that's when it eventually turns into the fossa ovalis, is what you can see on the gross anatomy of the heart. So this one shuts immediately. There's no question about it. This one shuts as soon as the baby takes its first breath. But what's interesting is it can remain patent, so it can remain open, and that's known as a PFO, a patent foramen ovale. There's a 25% incidence. So that means like 1 in 4 people probably have a PFO. They have no idea about it, which I think is kind of wild. But it really doesn't do much, like having that open. Maybe some of the blood, because now it's the left side of the body is more strong anyway than the left, like the left side of the heart is stronger than the right side of the heart. So it's like, okay, like it's fine if it remains open. It's not like the biggest deal in the world. But this one shuts super quick, like immediately. The last shunt is the ductus arteriosus. This shunts blood from, so in utero, it's a right to left shunt, and we talked about why. So it shunts blood like this. It's absolutely critical to remain open during utero. So mom actually produces what's known as prostaglandin E2. You guys might have done the arachidonic acid pathway in POEM. It kind of makes a little baby comeback now, because you need to know prostaglandin E2 maintains patency of the foramen ovale in utero. That's actually why like pregnant people can't take Advil, because Advil blocks cyclooxygenase, and you need cyclooxygenase to make prostaglandin E2. So if you take a COX inhibitor like Advil, the ductus arteriosus is not going to remain open, and it's going to close. So that's not good. As soon as the baby is born, this high level of oxygen, as well as the low level of prostaglandin E2, which again is maintained with the placenta. The placenta it undergoes the arachidonic acid pathway a lot. That's kind of what allows the process to close. So it remains open because there's very low oxygen and there's lots of prostaglandin E2. But if you were to block prostaglandin E2, it would start to shut, which is what you don't want in utero. This is the last shunt to close. It closes within 2 to 3 days. I remember this. I shared this story with the live session. I had a classmate who had just had a baby at the time. We were in cardio block, and he actually said when the baby was born, he was listening with the stethoscope, listening to the ductus arteriosus close after like the few days after the baby was born. I was like, that's so nerdy, but it helped me remember. It did help me remember. It can remain patent, and that's when you have what's known as a patent ductus arteriosus, or a PDA. This is a murmur, so when I have all the congenital cardio stuff later for you guys to review, it can remain patent, and then there is a lot of clinical relevance to having a PDA. But one of the main things that happens is if it remains open after birth is it's not a right to left shunt anymore. It's a left to right shunt. So we have blood going. So kind of this arrow kind of reverses because the pressure system changes. Now the left side is a lot stronger than the right side once the baby is born. And so this arrow, so now some of the oxygenated blood goes back into the pulmonary artery, and it just kind of like circles around and around and around. And that's a characteristic murmur that you can hear. This is like a need to know slide. So the fetal structure during fetal development turns into what's known as a post-fetal derivative. So the main one, like I kind of mentioned to you guys, the foramen ovale turns into the fossa ovalis. You can see it on the gross anatomy slide of the heart. The ductus arteriosus turns into the ligamentum arteriosum. So remember, in adults with like post-ductal coarctation, it's going to be after the ligamentum arteriosum. It's just where the ductus arteriosus was. And then there's these other ones which are like a little bit more important in other blocks, but these are still fair game in terms of like multiple choice questions, just easy multiple choice. Like the ductus venosus turns into the ligamentum venosum, the umbilical arteries turn into the medial umbilical ligaments, and then the umbilical veins turn into the ligamentum teres hepatis, which is located in the falciform ligament, which is a GI anatomy type thing. I want to mention here the umbilical arteries turn into the medial umbilical ligament. We're going to talk about something in renal where it's the median. It turns into the median, IAN, umbilical ligament. Do not get those confused because they know it's tricky and they like to ask about it. All right, so umbilical arteries, medial umbilical ligament, okay? And then very brief embryo, because again, I don't think everyone's going to be taking STEP, which is fine, but that's why I have this in here for people that are wanting to take STEP. At a very basis, just understand that the mesoderm is giving rise to all 3 layers of the heart that we talked about, so the myocardium, the pericardium, and the endocardium. And then the primitive heart. So at a very, very, very at least basis, you need to understand like the heart tube and how to label it. And the reason why is because of these congenital cardio defects. Like it can say like, oh, there's an issue with the fetal truncus arteriosus. So what's going to happen when the baby's born? Like, what's the heart going to look like? So you at least kind of have to understand like labeling this heart tube as well as this process of like looping and like all this stuff. So there's this video here. It's a really, it's like a claymation video from like the 1980s, but it's fantastic. Even Dr. Ryan of Boards and Beyond, he literally taught, and he's a cardiologist, and he was like, this video is awesome. Like, he even talks about it in his slides. So the next several slides are basically going to be this video in words. Just hold, if you're interested, watch it regardless if you're interested in taking step, like you still need to know this video at a baseline. But if you want to know like the really small details, like just take notes on the slides that I provide coming up. So atrial septation, again, it's just a lot of words, but the process is basically, because like things like this, like the endocardial cushion, like you need to be like, oh, like that's going to turn into the eventual like septum in between the right atrium and left atrium, or like where the valves come off of. Because again, they always ask like, oh, this valve is defective. What embryonic structure might have been the cause of it, or something, you know what I mean? Something like that. But this process kind of goes into it. And then I have through here, but what I did want to point out is like, this is kind of like the foramen ovale. So this is kind of like, see how there's what's known as a septum secundum as well as a septum primum. It's kind of allowing a little gap in between. That's your foramen ovale, because we want that interarterial connection or communication. But as soon as the first breath closes, these two connect, and now there's no, like, you can't get blood there. This is it in words. Thank God we're not going through it. It's a lot of painful. I hate lots of words on a slide, but this is all pretty much what I was talking about. Here's like the first breath I was talking about. Just kind of watch it with the video. Ventricular septation, same thing. They'll talk about like this spiraling is pretty cool. It's also in that video. And then it kind of talks about the development of the IV septum, the endocardial cushions. There's neural crest cells. They love to ask about neural crest cells. So neural crest cells, but these are all implicated in the pathology states. Valve formation, same thing. Where do they come from? And then kind of like a little summary. Another thing too is understand cardiac looping. So this U loop, or this S-shaped heart, it undergoes a U loop. It happens around week 4. So in between 24 and 28 days is when you have like that looping. And then kind of like a path tie-in is there's this syndrome. It's called Cartaginer syndrome. Cartaginer syndrome, it actually is more so implicated in palm block. I don't know if they asked about it in palm block. Definitely they will in second year. But also in repro block, Cartaginer syndrome will come up. And Cartaginer syndrome is basically like, so they say it's caused by it's a defect in cardiac looping caused by a defect in the dynein arm of microtubules, results in Cartaginer syndrome. So literally there's a process of the cardiac looping that affects, because these microtubules are like defective basically, the cilia. Anything that has cilia, those are all microtubules. So that's why in repro block, it's important to understand like, oh, like cilia, like you might have Cartaginer syndrome if you have a defect in cilia, as well as the fallopian tubes have cilia. So you can also see like reproductive issues with Cartaginer syndrome, because if you don't have proper cilia, you can't like catch the egg, which you guys will all do in repro later. But it's relevant for this block because Cartaginer syndrome usually presents with dextrocardia. So dextrocardia is where the heart, this is a normal chest x-ray, so this is still the right side, this is the left side. The heart's on the it's just flipped around. So it's kind of like, now the apex is over here. So the heart is like literally in the wrong direction. Patient would have absolutely no idea until they got a chest x-ray. You're like, oh. But not only is there dextrocardia, there's also situs inversus. Situs inversus is where all the organs are on the opposite side of the body. So here's the liver over here on the left side, and you're like, oh my God. And this is probably the stomach over here. Actually, I have no idea what that is. Stomach's up here. So that's probably like a intestine of some sort. But regardless, all the anatomical organs are flipped. That's situs inversus. And what's really cool about situs inversus is you have no idea you have it. So even like in the cadaver lab, like I heard like before I even got to Rowan, there was a cadaver dissection where they cut open the patient and everything was on the wrong side, and they studied this entirely backwards. Like they just didn't put 2 and 2 together, and they just did everything backwards and studied it all backwards. So it's wild. You have no idea until like an autopsy basically. So it's all normal, but it's just something to keep in mind. Like this is a defect in embryo that can lead to this pathology state. And then this is just like a chart of the embryonic structures. Remember how I said earlier I talked about what trabecula were? That's why. Some of the cardiac structures give rise to trabeculated portions versus smooth portions. Remember, trabecula is like the muscular layers versus smooth is smooth. So this is important to know. Unfortunately, always understanding the fetal derivative, the fetal structure, and what its like adult baby derivative is really important. Okay. So this is your quick summary. This is at an absolute baseline. You need to know this. You need to know how to label this fetal heart tube, and then how to know like what does it develop into eventually, because this is where they'll ask the questions about the congenital cardiac defects. They'll be like, well, what part in fetal development probably went wrong? And you're like, oh my God, I have no idea. So as long as you have like a general idea, you can probably do it. Just watch that video. It's only like 9 minutes, I think. It's awesome. It's such a cool video. But it's important to understand that, to understand these congenital cardiac defects. I lied. I said I was going to go through these. I am not going to go through these because this is already super long, and I know you guys are just patiently watching this. This is super high yield, so do it as an LI. When you eventually come to study it, reference back to these slides, because I have like my little tricks of how I remember like right to left shunts versus right to left versus left to right shunts, how you can pick up on it in utero, and which congenital cardiac defects line up with these early cyanosis versus like a later cyanosis. These are like my little tricks for it. But it's all in here. It's all in here for you guys to kind of go through. And it's just very quick, like 1 to 2 slide summaries on all of this stuff. And this is all stuff you have to know. I also highlighted things that I think are important that can help you identify like the type of congenital cardiac defect that it is. So I'm just going to slide through these really fast. Tetralogy of flow is really important. Okay, going. Again, I put on here these like PDA, PFO, what it's associated with. Oh, I did want to talk about, I skipped this in the live, but I think this is important. There's a concept known as a paradoxical emboli. And no lie, first year when I went on my preceptorship, someone just gave an LI on like PFOs and paradoxical emboli, and literally on my preceptorship, I diagnosed it in like my preceptor's patient, and he was like, oh my God, that was awesome. Like, what year are you? Are you 3rd year? And I'm like, I just started med school like a month ago, and it just made me feel cool. I was like, PDL baby, you know, I was like, that was so cool, because someone did an LI on it, and I remembered it. So I want to talk about what paradoxical emboli is, but it's basically, remember how I said 1 in 4 people have a PFO without knowing it? Well, let's say you have a DVT. So remember, DVTs are clots that form in those deep veins, like in the legs. So clots can form, and then it can go back to the heart. And if it goes back to the heart, it's usually not a big deal, because the lungs have like natural anticoagulants in the lungs that can break down those clots. And usually it doesn't go to the brain, and it's fine. Usually DVTs can't cause strokes. Usually strokes are caused by like atrial fibrillation, where it's already on that side of the heart. But a PFO, if you have a PFO, so remember, PFO is like, it's open between the right atrium and the left atrium. This clot coming from the veins can go into the right atrium, then it can go it can go into the left atria, which is over here. So it can come in, it can just go swerve into this left atria, and now we have a clot in the left atria, which shouldn't have happened. Like, this should not happen if this was blocked, and it goes here and it goes through the pulmonary system, and then the pulmonary system kind of gets rid of this clot. So this is what's known as a paradoxical emboli. It's paradoxical because it's a venous clot that goes to the systemic circulation, so it's paradoxical. Usually you can't have like venous clots going to the arterial circulation. Like, that's just weird. It just doesn't happen. So they call it paradoxical, and usually it's because the patient has a PFO. So they do echo. They're like, oh yeah, there's a hole right in between the left and right atria. And then you're like, yep, that's what caused your stroke. You have a PFO, and then you had a DVT. Okay, and then mediastinum. So like I mentioned yesterday, mediastinum there's a lot in the mediastinum. You really don't need to know it. I more so put this on here for completeness of just how much stuff is located in the mediastinum. What I do want to mention, which I didn't mention yesterday, was you can subdivide the mediastinum in between basically where the superior part and then the inferior part. And it basically, the superior and inferior part is separated by the angle of Louis. So angle of Louis, sternal angle, you know that from OMM. You go down the sternum until you feel a little divot, and then you know you're at the level of T4. So the superior mediastinum would then therefore be anything up here. The inferior would be everything down here up until the diaphragm, but the inferior mediastinum can be further broken up into anterior, middle, and posterior, which looks like this. So sternal angle. So it's more so like a landmark for anatomy to understand that the sternal angle is kind of what separates these two, rather than knowing everything that's in here. So like I said here, I didn't want to not include it, all of these different things that are included in the mediastinum. You do not have to memorize this. You don't have to know this. It's really just here for completeness. But I am going to stop. So I'm going to kind of go through these, but I am going to stop at certain ones to tell you like certain things, like this, for example. So remember on the first slide, or one of the first slides, I said like, oh, the thoracic duct makes a comeback and it has like an anatomy tie-in. You probably did thoracics in palm, but I just wanted to make sure to cover it just so it's like all the bases are covered. The thoracic duct on the left side, it drains basically into what's known as the left venous angle. And the left venous angle is basically where the left internal jugular vein and the left subclavian vein meet. So remember, everything's draining back into the superior vena cava, so it's moving this way. They come together at like this left sternal angle. That's where the thoracic duct drains into. It drains into this left venous angle, and it goes back to the superior vena cava. Same thing with the right lymphatic duct, just on the right side now, it drains into the right venous angle. So the right subclavian and the right jugular, where they kind of come together, that's where it drains into. So just like a cool thing to know too, like all the lymphatics drain back to the heart, and that's why it goes through this venous system. Also pointing out, all the veins are sitting on top of the arteries. Always a good anatomy plug. The nervous system, just know like the sympathetic trunk is in here, but that hopefully makes sense because T1 to T4 innervate the heart, so it needs to be near it. The digestive layer, again, we're not talking about any of this really. But what I do want to mention too is, remember we talked about the thymus? This does have a relevance in immuno, so we're going to get very cozy with the thymus in immuno. But for now, just keep in mind, you might see pictures with the thymus and without the thymus. They're both normal. Don't worry about it otherwise. But that technically would be located in the mediastinum. And then just finally, like a last type of path, I guess, tie-in. So this aortopulmonary window, so where the aorta and like, I guess the lung pleura meet, that's what's known as like the aorta pulmonary window. If that gets compressed, so if they say, oh, there's like a tumor at the aorta pulmonary window, or like something happens at the aorta pulmonary window, that's exactly where the left recurrent laryngeal, that's exactly where the vagus nerve kind of scoops under the aorta, right at this aortopulmonary window to become the left recurrent laryngeal nerve, and that's when you can get hoarseness. So hoarseness, again, look for that terminology in questions, the like compression of the aorticopulmonary window. The next thing I wanted to kind of anatomy thing is to be able to look at a CT scan and orient yourself and then label the necessary structures. But we're going to do this really nice and easily. So we can already tell without even like knowing too much about orientation, they're laying on their back. I mean, the vertebra is here, the sternum is here. So you're like, cool, they're laying on their back. But now it's like, okay, are their feet facing away from you? Or are their feet facing towards you? And you're like, great, that is a great question. So what you want to do is, because now you know with anatomy, that the right ventricle is located directly behind the sternum. So if the right ventricle is directly behind the sternum, you know that this must be the cardiac apex, because it sits that way in the heart. So you know that this patient must have their feet facing towards you. So they're laying on their back with their feet facing towards you. And then all you have to do is imagine them, so they're on their back, and now they're sitting straight up facing you. That's how the heart would look in the chest. It would look like this, that's a horrible heart. But that's how it would look in the chest if they just sat up and so they're laying down, feet away from you. Now their head is my fingernails. Now they're leaning up towards you. Then the heart would sit like this in the chest, where it's like this is the apex down here. Luckily, I don't need to be an artist to be a doctor. All right. And then the other thing I wanted to mention that you can get from like a CT scan or just like from like a transverse cross section like this is, remember how I said the right ventricle directly behind it in the back is the left atrium? Here's your left atrium. I wanted to point out how close the left atrium is to the esophagus. So left atrium, here's the esophagus. So there's a path tie in here that anything that causes left atrial enlargement can cause dysphagia or difficulty swallowing. And that's why. It's because if the left atrium gets bigger, it's going to push right on the esophagus, and that can manifest with just difficulty swallowing. So like a classic example would be like some sort of mitral valve disorder, like mitral valve stenosis classically causes left atrial enlargement. It can just push on the esophagus. And this x-ray picture, this is BS. You can't see left atrial enlargement on a chest x-ray. So I think that's personally BS. Oh, just kidding. This is doing a barium swallow. Ignore me. You'll learn about barium swallows and GI block. But just keep in mind, left atrial enlargement, dysphagia. So if a patient is presenting with dysphagia, even in your cases, your case, like your PBL cases, be like, okay, this patient has difficulty swallowing. Maybe they have like a mitral valve issue that's causing left atrial enlargement. And there you go. Here's the mediastinum from the left. Here's the mediastinum from the right. And then finally, we're going to talk about retroperitoneal structures. So retroperitoneal structures, like I said earlier, remember when I talked about abdominal aortic aneurysms? If it bursts open, the patient's going to have like severe back pain. It's because the abdominal aorta is in the retroperitoneal cavity. It's a retroperitoneal organ. So retroperitoneal, you have to understand what peritoneal is. So the peritoneal cavity, and again, this is a GI block thing, so I'm not giving you too much information on this, but so don't even memorize this picture, but everything highlighted in yellow, that's the peritoneal cavity. And the peritoneal cavity is just, it's a potential space. It's a cavity. It's just open space, but it's in between the layers of the peritoneum. It's kind of like the pericardial cavity, the pleural cavity. It's kind of just, it's all the same thing. Like it's all variations of a theme, but that's the peritoneal cavity. Retroperitoneal means it's behind and outside of this cavity. So this is the front. Here's your thoracic vertebra. So this is the back. So this is the front of the body. So that's why so everything that's not highlighted in yellow is considered retroperitoneal. So it's important to know what organs are located here to make sense of, I feel I have back pain, or I have pain that radiates to my back. That's exactly how they're going to word it. And there's different things that all do this, but the ones that are relevant for this, for at least for cardio, is a dissecting aortic aneurysm. And we're going to talk about the difference between just an abdominal aortic aneurysm versus like a dissecting aortic aneurysm. At the time, Dr. Scally loved aortic aneurysms and like dissecting aortic aneurysms, so he would always ask questions about it. But I don't know anymore. I don't know how Dr. Genora feels about dissecting aortic aneurysms. But regardless, since the abdominal aorta is considered retroperitoneal, that pain is going to be radiating to the back. And we'll talk about some of the kidney ones and when we do kidney anatomy. But for here, for example, so this is the first aid image. I kind of highlighted what the peritoneal cavity is and like everything that would be included in the peritoneal cavity, and then everything that's outside of it. People remember all of these retroperitoneal organs with SAD pucker, and SAD pucker is the mnemonic. So the A in SAD pucker stands for the abdominal aorta as well as the AVC. The inferior vena cava, the IVC. So here's your aortic dissection. So the question we got yesterday is, what's the difference between an aortic aneurysm and aortic dissection? They're very similar, very, very, very similar. Very similar causes. Everything's pretty much the same about them. A dissection, so an aortic aneurysm, remember, it's just like a bulge that can rupture. The difference between a true aneurysm, like a true bulge, versus a dissection is with the dissection, blood actually tears through one of those three layers. So it tears through like the intima, media, externa. It tears through one of those, and then blood pools, and then eventually that can rupture. That's your dissection. So when there's a tear, so that's kind of what makes it a difference between an aneurysm. It's going to look similar to an aneurysm, but it's not a true aneurysm because the blood is what is making it look like an aneurysm. But it's going to be similar to the causes. So Marfan's and Ehlers-Danlos, there we go. These connective tissue disorders just make it more likely for blood to kind of pierce through one of the layers. Patient will complain of tearing chest pain because there is a tear, but it's going to radiate to the back because, again, the abdominal aorta is retroperitoneal. This is an absolute emergency. I think this was Dr. Scally's one of his favorites because this is how John Ritter died, the actor John Ritter, who Dr. Scally like absolutely loved. And John Ritter died because they thought he was having a heart attack. And for a heart attack, you just do an EKG, and they're like, oh, your EKG looks normal. For an aortic dissection, you have to do a chest X-ray. Must. And if you see a widened mediastinum with this tearing chest pain that radiates to the back, that's pretty much, you can be like, all right, you have an aortic dissection. But they just did an EKG on John Ritter. EKG looks fine because the EKG shows it just talks about the electrophysiology of the heart. The electrophysiology is fine. It's just blood is seeping back into one of the three layers of the aorta. So they didn't do a chest X-ray. He died. So it's really important, again, tearing chest pain radiates to the back, widened mediastinum on chest X-ray, that's your dissection. You can do a CT scan, usually they don't, but for test questions, they will like throw one on there and be like, oh, like what's the false lumen? And I'll show you that in a second. So you don't have to memorize types of aortic dissections. It's more so just showing you there's different places that the aorta can, like the blood in the aorta can dissect through. So the pink layer is kind of like the layer of blood that dissected through one of those three layers. So it can happen up here, it can happen here, it can happen like over here. But see how it can kind of look like like an aneurysm? You're like, oh yeah, that kind of looks bigger than it should be, but it's not the cause of it. Like the aneurysm is not the cause. Now blood has dissected through. It's just you're bleeding into the mediastinum, basically. Another picture, aneurysm versus dissection. Aneurysm, bulge, all three layers. Dissection can still look bulgy, but it's because blood has now dissected through. Here's what a wide mediastinum looks. It's very obvious compared to like your normal cardiac shadow. And then on CT scan, if they were to do a CT scan, it's this concept of a true lumen and a false lumen. So again, remember your true lumen, this is like your true aorta. So that's like where blood is going to be coming through, going to the rest of the body. But since we've now pierced through parts of the walls of the cavity, and now we have an basically like a second aorta, kind of, sort of, but it's not really pumping out blood to the rest of the body. It's just kind of there. It can get picked up on CT scan. But why they like to ask about this is usually they won't be labeled, and it's like, oh, which one's a true lumen, which one's a false lumen, and everyone wants to call the true lumen the bigger one because it's like, oh, obviously that's the more important one. But that's not what's remember with dissections, it's dissecting through one of the three layers. And remember, all three layers are what allow the aorta to be super compliant. To be not super compliant. But now if you dissect through one of them, now you only have two layers, it's going to be more compliant. So it's going to get bigger than your true lumen. So that's kind of why like this whole idea of a false lumen and a true lumen, they can tie in so many different concepts with this. But it's usually always going to be the bigger one on CT scan. That's going to be the false lumen. Okay, we made it. All right, so renal anatomy, not as long as cardiac anatomy. Thank you all for bearing with me. But before we start, so here are my like little renal tips for you guys overall. Year one, like I said, it's physio, but specifically for the renal system for first year, it's nephron physio, which I'm really not doing nephron physio today. I'm not even going into like the different parts of the nephron, like the transporters and stuff. Do whatever you have to do to just memorize absolutely everything about every part of the nephron. Heavily tested concepts, again, nephron, obviously. Like, I feel like when they just need a question, they ask about nephron and nephron physiology. Some other stuff that don't really have to do with nephrons are like electrolytes, acid-base balance, and the RAS system. And again, I highlighted this because I also mentioned RAS was important for cardio. RAS is like a really good, it's like a really good, what am I trying to say? Like cardio-renal tie-in pathology state, which is why they like to ask about it, because it's like heart failure that leads to the kidneys trying to compensate, and then the whole body just like dies. Like that's basically like RAS is not great, so that's like yeah. But anyway, there's also fluid shifts that come up a lot between the ICF and the ECF. Diuretics, and before you guys are like, well, we're first years, we don't have to know diuretics. They do kind of like, it's kind of like how they get away with asking embryo without being allowed to ask embryo. It's like, oh, it's embryo it's like embryo in the context of path. Like they need to know path, and then the school is like, all right, fine, like I guess. It's kind of the same thing here. It's like the diuretics, they ask the diuretics in the context of physio, so they get away with it. So you do need to know the diuretics. You don't have to know like absolutely everything about the diuretics. It's more so like, where are they working on the nephron? What are some things like, what are they, like how are they being a diuretic? Like very physio heavy concepts about the diuretics. And then the last thing I want to mention is diabetes insipidus. It's really not heavily tested. I probably shouldn't have had it as heavily tested, but it's just like something that I think people don't think to study this block because it's like a very like endo thing. But in terms of like diabetes insipidus, it's an issue with ADH. ADH works on the nephron. There's your tie-in. So that's how the nephron gets like tied in with all of this stuff. So just don't ignore some of the stuff that you think would be tested in future blocks. So in terms of the kidneys, like to do kidney anatomy, there's something to understand about the kidneys is that there's two components. There's like a vascular component as well as a urinary component. So the vascular component is like, all the renal arteries and their branches as well as the renal veins. The urinary component is like, that's your nephron. That's like collecting the urine, concentrating it, reabsorbing electrolytes, whatever, and then emptying out through the urine. So this is just kind of like a picture of a kidney. Again, they did like a coronal cross section, and we're gonna label some important things. But what I really like about this picture specifically is they said what parts of the nephron are located in like this more gross anatomy-ish labeling of the kidney. So what I mean by that is this is your kidney. So this is, oh, my dog made an appearance. So this is like your kidney. So here's the renal artery, and I think the next slide I have, you should know the branches of this renal artery. It like branches into a bunch of different arteries, like all the way down to the cortex. The renal vein is here. It comes out like this. And then from here, there's the cortex and the medulla. And this is not specific to the kidney. Lots of things have cortex and medullas, like the adrenal glands have a cortex and a medulla. It's just cortex means outermost portion, and medulla means more innermost portion. Usually the medulla starts where these renal like papilla are, like these like the renal papilla, the pyramids. Well, not the pyramids, the papilla. But that's usually where the medulla starts, and it goes all the way down to like basically where the hilum is. So the kidney does have a hilum, just like the lungs have a hilum. It's just where all this stuff kind of like comes together. And then cortex, medulla. There's also things known as calyces, which are right here. So a calyx literally means cup in Latin. So it's literally like it's collecting the urine, and you'll see this is kind of where the urine collects into after it comes from the collecting duct. It collects into a calyx. Then the calyx drains into the pelvis, and then the pelvis goes out to ureter, and then you're able to like excrete urine. All right, so here's the renal arterial system. So again, know this. Should have put like a big star here. So the renal artery branches into the segmental artery. Where even is it? Yeah, superior segmental. The segmental artery. Then it goes to an interlobar artery, which I wish it went in order. Interlobar, and then an arcuate, and then interlobular, and then it goes to the glomerulus. And the glomeruli are located in the cortex, which is back here, which I've talked about, which I'm going to talk about. And then the other thing too is the renal vein, which is not in this image. It drains in the opposite direction to the IVC. I noticed on the PowerPoint from the live session, I had that it drains in the opposite direction to the portal system. It's not technically wrong, but IVC is more technically correct, so we're going to go with IVC. So just you can make that change on that other PowerPoint. And it'll make more sense when you get to GI anatomy. You're like, okay, yeah, I get it. Because the portal system, we're not going to talk about it. But so it drains into the IVC directly. So this, it is a papilla. Oh, I did call it papilla. Okay. So this is your renal papilla. So this is another like coronal cross section of the kidney. And what I wanted to kind of point out is that we're going to zoom in a little bit on the papilla, which is why I have it like opened. But some other kind of stuff to point out is the papilla is like the entire thing, like the entire, I called it like a fan, like, you know, like one of those fans that people like go like this and like fan themselves with. It kind of looks like a fan. And then within the fan is going to be the pyramids, which are going to be these little thingies within the fan. Okay, so that's the difference between, that's why I was getting confused with the pyramid and the papilla. I'm like, those are kind of the same thing. But just know the papilla, if they pointed, and I think that's why I put this in here, if they pointed to a picture, like if they had a kidney like this and they pointed and they were like, hey, you're like, and they're like, what is this? You'd be like, that is a papilla. Okay, so that's that. We're going to zoom in into the papilla because the papilla is what contains the glomeruli and that whole renal network. So again, it's labeled cortex and medulla. They separated outer and inner medulla. It's just everything that's containing basically where the pyramid is. So the cortex is going to be comprised, and I really like this picture because it shows the arterial system that I talked about as well as like the urinary component. So it has like the glomerulus and the arterial side as well as like basically the rest of the nephron, Bowman's capsule, the PCT, all that stuff. So this, I also really like this picture because it kind of helped me realize, which is something I didn't realize first year until I got to second year. I was like, oh, that makes sense. I thought every nephron had one collecting duct. So it was like nephron collecting duct, nephron collecting duct. That's not how it is. It's like one collecting duct for all these different nephrons. And the collecting duct, I mean, the name is beautiful. It makes complete sense. It collects all of the urine from all of these nephrons. And then the collecting duct goes into the calyx to the pelvis out to the ureter. So here is kind of like where the urinary portion of the nephron. So here's the glomerulus, which is more of it's over here. It's more of the vascular portion. But so here is the the glomerulus, then the proximal convoluted tubule. There's a proximal straight tubule that happens after it. Then it has your intermediate tubule, which is just the descending limb of the loop of Henle. And then you have the ascending limbs of the loop of Henle's, distal straight tubule, distal convoluted tubule, and then collecting ducts. Something to note, and this was just like it was like mentioned very like briefly in Costanzo, but I think they actually asked, this was on my exam, so I just remember being annoyed that they asked this, so I wanted to put it on here. Not saying that it would be on yours, but there are two types of nephrons, and you can actually see them both in this image. So they're named for where they are, where their glomerulus is. So it's like, where's their glomerulus? Is it in the cortex or is it closer down to the medulla? So if we look, here would be like a cortical nephron because its glomerulus is up here in like the cortex. Here would be like a juxtaglomerular nephron. Actually, I don't even think that's this would be like a juxtaglomerular nephron because its glomerulus is located closer to the medulla. And also you look at loop of Henle size. How long is its loop of Henle? Cortical nephrons have really short loop of Henles. Juxtaglomerular nephrons have really long loop of Henle's. So most of our nephrons are cortical nephrons. They're located close to the outer part of the renal cortex. They have short loop of Henle's. Juxtaglomerular, only about 15%. They're just like further down in the cortex, near the beginning of the medulla, and they just have very, very, very long loop of Henle's. So just know that we have more cortical nephrons than juxtaglomerular nephrons. It's just a fun fact that PBL exams like to ask. So next is the renal corpuscle. So the renal corpuscle is basically it's like the first part of the nephron, but it's combining the first part of like the vascular part as well as the first part of like the urinary part. So the renal corpuscle is basically the glomerulus plus Bowman's capsule. So this is always going to be in the renal not always going to be in the renal cortex. Oh yeah, it is pretty much always going to be in the renal cortex. Even the juxtaglomerular, they're still going to be in the renal cortex. But they're comprised of the glomerulus, which again, that's the vascular part, enclosed by Bowman's capsule, which is the urinary part, which is what I have here. And the function of the glomerulus and the renal corpuscle in general is to filter blood. That's what the kidneys are supposed to do. They're supposed to take what they want out of the blood, excrete what they don't need, and then refilter, retake back anything that they want, that they can get, like, that they can bring back to the rest of the body. And then I put here, recall that the glomerulus has size and charge selectivity. I really didn't do too much renal histo, like with the podocytes, but you should still know that. I'm pretty sure Costanzo goes into that. I just don't think it's too difficult, and I wanted to keep this more of like a, like tie in the anatomy to like the path and the embryo. But just keep in mind that there is that size and charge selectivity of like at this like level right now at the renal corpuscle. So basically what happens with the glomerulus is blood flow comes in through the afferent arteriole. So afferent blood's coming in, and then it goes through the glomerulus, this capillary network. It just going, whatever like the whatever it undergoes its size and charge selectivity, whatever it needs, whatever it doesn't need, it goes back through it empties whatever it needs out into the through Bowman's capsule on its way to the proximal convoluted tubule or the proximal straight tubule, proximal convoluted tubule, whatever. Some sources say that it's there. Some sources say it doesn't. It's not that big of a deal. But just know that you can see some sources say there's a straight tubule for the proximal and distal, but some sources just call it like the PCT. That's what I do. And then out here, then it goes back out, and then this would go, the efferent arteriole would bring it back to the rest of, back to, blood flow. So on here, another thing to kind of note that's important is which I have highlighted here, is the location of the distal tubule, how close it is to the beginning of like the renal corpuscle. And I think like when people are first learning nephron, they are like, oh, it's the proximal tubule, loop of Henle, distal tubule, collecting duct. When in reality, the distal tubule is really close. It just like, the nephron like loops around. I have a picture to show this, but it's just really important to understand that how close this distal tubule is to the start of like basically where these efferent and afferent arterioles are. It's just really important to understand that. And it's also really important to understand that the macula densa, so when you're reading about the macula densa in Costanzo, it's a part of the distal tubule, and you're going to be like, how is the macula densa affecting what happens with like the beginning of the glomerulus? Isn't it all the way down in the distal tubule? So that's one thing, understanding that it is in the distal tubule, but it's really close technically to the start of the glomerulus because the nephron like loops back around. And then there's other cells to keep in mind. They're called juxtaglomerular cells. So these juxtaglomerular cells are also like going to be mentioned in Costanzo. So it's kind of just important to know here's where they are. They're juxta, they're next to the glomerulus, and they're kind of like almost lining the afferent and efferent arterioles. Right? So this, again, I think this is how everyone draws a nephron, how everyone thinks about a nephron. It's not correct anatomically. That's my job, is to tell you what it looks like anatomically. But this is, again, they zoom in on one of these papilla. So they zoom in on it. And now you have your vascular system. So again, it goes through afferent, leads through efferent, and then you have the rest of the blood flow, rest of the capillary system, and then whatever is going to drain back out through the renal vein. And then whatever needs to go out through the urine, it leaves, and now it goes through the urinary component of like the nephron. And then so here's the urinary component. It goes from proximal convoluted tubule, loop of Henle, through the thin descending limb, loop of Henle, thin ascending limb, and the thick ascending limb, distal convoluted, collecting duct. But remember, normally there would be all these nephrons branching off of this, which is something I didn't know. Okay. Yes. All right. So again, note the proximity of the distal convoluted tubule to the renal corpuscle in reality. This is in reality how it looks. So when they talk about feedback mechanisms, they're going to be talking about all sorts. I think it's called like tubuloglomerular feedback or something. Tubuloglomerular. The distal tubule is having a feedback mechanism on the glomerulus. And if you don't understand that the distal tubule is so close to the start of the glomerulus, tubuloglomerular feedback is going to make absolutely no sense. Take it from me. It made no sense to me first year. I was like, I do not understand how this works if they're not right next to each other. So I'm just saving you some rabbit hole time surfing on the internet, trying to make sense of this complicated feedback process. It hopefully will make a lot more sense understanding that this is how nephrons look. The distal tubule is located very close to the start of the glomerulus. All right, I'm done talking about it, I promise. But also, this would be like a cortical nephron, short loop of Henle, located like closer to the outer edge of the cortex. This would be a juxtaglomerular nephron, very long loop of Henle. The glomerulus is located closer to the start of the medulla. Still in the cortex, but closer to the start of the medulla. So that would be like the juxtamedullary nephron. All right, so same slide on retroperitoneal cavity, but now I highlighted the relevance for renal. So the two that are kind of relevant for renal is pyelonephritis. So pyelonephritis is a kidney infection. Kidneys are retroperitoneal. So a lot of the times when someone has a kidney infection, they're going to say, oh, I have low back pain or flank pain. And that's why, it's because the kidney is retroperitoneal. Kidney stones. So kidney stones obviously start in the kidney. So they start in the kidney, but sometimes they can get big, and then the kidney starts to pass them, which super painful, right? But then they can get lodged in the ureters. And the ureters are also retroperitoneal. So everyone thinks that if you have kidney stones, you're gonna have groin pain. You might if the ureter starts to come forward, and we're going to talk about like a weird anatomical thing with the ureters. They do actually come forward, but when they start and when like the kidney stones would get lodged, they would get lodged in the back, like where they're first coming out of the kidney and they're too big to even pass anymore. So they like basically lodge in the back. And then Sad-Pucker still applies here. So the U in Sad-Pucker is for the ureters, and then the K in Sad-Pucker is still for the kidneys. This first aid image doesn't have the ureter on here, but just imagine, yay, here's a ureter. All right, weird anatomy things. The right kidney is smaller than and not as high up as the left kidney, so any guesses why? No one's here, but if you pause it and think about it, it's really just because the liver's in the way. That's it. The liver is nope, we're on the right. Anatomy brain. So the liver is blocking the right kidney from ascending up, because we're gonna do a little bit on kidney and embryo. The kidneys are formed basically down here, and then they ascend upwards in the abdominal cavity as the fetus starts to develop. So the right kidney is just completely blocked by the liver because the liver's already there. So it's like, okay, this is where I stop. So just keep in mind that the right kidney is like a little bit lower than the left kidney, but we're going to talk about this. They sit roughly between the levels of T12 and L3. This is just, again, for understanding of like Flank pain, like when you're saying like true low back pain, flank pain, it's going to be around from T12 to L3. So you can do your little OMM landmark thing and then kind of like palpate down and up. Be like, okay, that's where the kidneys are. So the weird ureter thing I was mentioning, so this is a good picture kind of. So the ureters are like kind of in the back because they're retroperitoneal. Then they come forward. So here's them coming forward. You can't really see them in the back because this is like a front view of this patient. The ureters sit on top of the psoas muscle. So the psoas muscle is here in green on both sides. They sit on top of it. And for whatever reason, this is just like a beloved kidney anatomy fact. I don't know why, but the ureters sit on top of the psoas muscle. The psoas muscle you'll do a lot of with OMM. The psoas muscle is really important for hip flexion. So even if you're sitting here and you try to lift your leg up, that's your psoas muscle doing that. You can actually feel it contract. So that's your psoas muscle. Super, super important for hip flexion. And the ureters go on top of it. Fun fact. And then the other thing to kind of know is that the left kidney has a longer renal vein. And remember, like I said, the renal veins drain directly into the inferior vena cava. The inferior vena cava is on the right side. So here's the inferior, because again, the aorta is on the left side. So the inferior vena cava is more on the right side. So the right kidney has a short renal vein that drains directly into the inferior vena cava. The left kidney has to basically cross in front of the aorta just to get to the inferior vena cava and dump its blood into the inferior vena cava. Okay. There is a pathology state I am going to talk about today, but I just want you to know going into it, it's going to come up more in repro, but I still think it's important to know for this block. So I'm still going to mention it, but it will come back. You're going to do it literally again in repro and be like, oh, okay. So this is just kind of showing, again, that the left renal vein has to cross in front of the aorta to get to the IVC. Here's another view of it. The right renal vein is really short and just kind of goes just directly to it. Another thing I want to point out with this picture is this superior mesenteric artery. So this is one of those branches of the aorta I said that I think you should know. The superior mesenteric artery is an artery, and now you're seeing it's on top of a vein. So you're like, oh no, like that is an anatomical no-no. And that actually is implicated in not a lot of, but a pathology state that I'm also going to talk about. Because again, anytime an artery is on top of a vein, the potential for the vein to get compressed is so high. So that's basically what happens here. All right. So this is the same thing. This is just from that PowerPoint, that anatomy PowerPoint for boards. The left kidney and the right kidney sit roughly between T12 to L3, but the left kidney is higher up than the right kidney. Another good thing to know is that the left kidney is bordered by the 11th rib. So rib 11 borders the upper part of the left kidney. Rib 12 borders the upper part of the right kidney. And again, just playing off of the fact that the right kidney sits lower than the left kidney. And like I said, it's a beloved anatomy fact. This was on this board exam, that to understand that the ureters lie on top of the psoas muscle. Not sure why it's so important to know, but it does. I think it's because they start in the back and then they go forward, and that's just like interesting. You're like, oh, that's kind of weird. I don't know. But all right, so we're going to talk about SMA syndrome. SMA syndrome is basically when the superior mesenteric artery crushes the left renal vein. And then it leads to this whole slew of stuff. So SMA syndrome, superior mesenteric artery, it's one of those branches of the descending aorta. Usually the SMA is surrounded by a fat pad to hold it in place. And I have a picture of this to show it to you. And that fat pad, it's supposed to be like not too much fat, but not so little fat. You want there to be like a nice buffer to make what's known as the aorto-mesenteric angle. And this is basically to ensure that the artery is not crushing the vein underneath of it, the left renal vein that's underneath of it. Another thing to understand with SMA syndrome, and we're going to talk about this in like a second, is that, and this is like the repro part of this, why you guys are going to cover it again in repro, is that the veins that drain the testicles on the right side, so again, this is obviously just in men, but on the right side of the so the right testicular vein drains directly into the inferior vena cava. The left testicular vein first drains into the left renal vein, and then the left renal vein drains into the inferior vena cava. Again, it's because it's on the left side, the left testicular vein can't just like cross over the entire body to get to the inferior vena cava. So kind of like has this indirect stop in the left renal vein. But first, I want to talk about the aortomesenteric angle. So this is a normal aorta, and do not memorize these. You don't have to memorize this. Just it's like more so to understand like a potential patient that would present with SMA syndrome. So normally we want the aortic mesenteric angle to be around 40 to 60 degrees. That's just where like here's like this is a duodenum, so this is just part of the duodenum. So this is going to come back in GI block, but also it's not shown here, but also the renal vein would be here. So like I'll draw RV would also be here. So pathological would be when this angle, like the fat pad is not there anymore or it goes away, it can crush the structures under it. So the duodenum, the right ventricle, and then this would be a case where, I mean, you're never gonna have to diagnose this on an x-ray first year, but it's like you see it how, I guess in this case, it was like squishing it. It was like 14 degrees, which is nothing. But so basically with this, what I'm trying to say is the typical patient you would see this in is someone that's maybe like obese and all of a sudden they lose so much weight so fast. They're going to just lose all this weight. This aortomesenteric angle is going to go down really, really fast. Normal weight loss over time won't lead to this condition. It's like rapid weight loss. So that's what you want to look for in question prompts is like rapid weight loss. And this is what I was mentioning earlier. Another thing to kind of understand, this is going to come up in endo repro like 1,000 times. Dr. Scally asked like 25 questions on this on the repro exam because it is a really big, important anatomical thing to understand. So here's the inferior vena cava. Here's the left renal vein or the left kidney. Here's the right kidney. So notice how the right testicular vein, so it's draining the right testicle, it goes directly into the inferior vena cava. The left testicular vein drains first into the left renal vein, which then crosses all the way over to get to the inferior vena cava, which it looks shorter than the right side, but this is just an image. You know that it crosses a really far distance to get to the inferior vena cava. Okay, so if you have something like SMA syndrome, which would crush this, so like let's say we crush this with SMA syndrome and the left renal vein gets crushed. The same thing that would happen with like jugular venous distension, with all the stuff, SVC syndrome, everything we've talked about, all this blood flow would then go back. So this green line now, all the blood would go back, and then you get engorgement of basically the veins directly surrounding the testicles. It's called the pampiniform plexus. And you get this engorgement of the pampiniform plexus. It's called a varicocele. So it's basically like, that's like a varicocele is because of this weird anatomy with the left testicular vein draining first into the left renal vein and then the inferior vena cava. So a lot of the times they'll ask like why are left-sided varicoceles more common than right-sided varicoceles, and it's because of this anatomy between the left testicular vein and the right testicular vein. Okay, so SMA syndrome can cause this, and it can get this backflow, and you can cause a left-sided varicocele. This is also called nutcracker syndrome, which I think is hilarious. Nutcracker, because okay. But basically the blood flow is going back, and then you can basically see, so the true symptoms of what makes it nutcracker syndrome is this triad. So it's this triad of hematuria, so blood in the urine, flank pain, because again, the kidneys are retroperitoneal structures, so the veins that are going to get compressed, that's going to be more retroperitoneal. And then left-sided varicocele, it's always going to be on the left side. You really shouldn't see nutcracker syndrome varicoceles on the right side. They're not impossible. Nutcracker syndrome on the right side is impossible, but a right-sided varicocele is not impossible if you have like a tumor or something blocking like this exact portion of where the right testicular vein drains into the inferior vena cava. Sure, it's possible to have a right-sided varicocele, but it's not as common as left side. Nutcracker syndrome usually only ever happens on the left side because of this this weird and anatomical feature here. Okay, so usually nutcracker syndrome is because of SMA syndrome compressing on the left renal vein, and then you get back up into the left testicular vein. So here's nutcracker syndrome again, caused by SMA syndrome. So here's your left renal vein. So remember in the other one, it was your duodenum, whatever. They're both right there, but duodenum's more GI. But here's your left renal vein, here's the SMA, here's your aortic pulmonary angle, looking great, 40 to 60 degrees. And then we have renal vein compression, probably rapid weight loss. All of this, like this fat pad kind of just disappeared. So now it went bloop and it crushed it, and now we get compression back into the testicular vein on the left side because that drains first into the left renal vein. Okay, so renal embryo. So the thing to understand about renal embryo, again, there's like a lot to renal embryo, kind of like with cardiac embryo, but what I'm going into is the ones that I felt were relevant for like an anatomy and embryo path sense. What at the bare minimum you need to know about renal embryo. So the first thing to understand is that there's 3 renal embryonic structures that happen in utero. The first 2 degenerate, and the third one is the one that becomes the kidney. All 3 of these embryonic structures sound very similar, so you do need to know which one's which one is the one that's first, which one's second, which 2 degrade, which is the third one, which is the one that forms into the kidney. So this is the 3 embryonic structures. So the first one's called the pronephros, neph for kidney, but pro, I guess you can think of pro as like first. So this is the first one. This degenerates around week 4 of development. Next is the mesonephros. So meso means middle because it's literally in between these 2. So it's kind of like the interim kidney from the time that the pronephros degenerates and the true kidney develops. So the mesonephros is the interim kidney. It's during the first trimester, and then it's going to degrade after the first trimester. An interesting fact for like repro anatomy, in males, the mesonephros actually turns into the vas deferens. So the vas deferens is the part of the male anatomy that like people can get vasectomies for. They just clip the vas deferens. You're clipping a fetal kidney derivative, which is so interesting. But we'll talk about that with repro anatomy if we get there. No, I'm kidding. So we're going to talk about that later. It's just like more of like a fun fact to know like the vas deferens developed from like a kidney fetal embryonic structure. And then finally the metanephros. This appears around week 5. It becomes the permanent kidney. And meta is going to hopefully be helpful to remember because there are 2 key structures to understand at this point, and meta is in one of them, so that can kind of help you. But the 2 key structures are the ureteric bud and the metanephric mesenchyme. And the ureteric bud gives rise to the ureter, the pelvis, the calyces, and the collecting ducts. And I bolded the collecting ducts because this is the only part of the nephron that's included that develops from the ureteric bud. So again, it's like a weird anatomy thing. They love to ask about it. The next other structure is the metanephric mesenchyme, and the metanephric mesenchyme gives rise to basically everything else that's not the collecting duct. So the entire nephron that's not the collecting duct. So the glomerulus all the way to the distal tubule comes from the metanephric mesenchyme. And basically what happens with kidney development is that the ureteric bud and the metanephric mesenchyme are communicating back and forth. So they're just going back and forth with their communication. And basically this communication allows for proper formation. So I say here, if there's like a bad interaction or if one is not communicating with the other, the kidney is going to be abnormal in some way, shape, or form. So here's just a picture of this. So here's the metanephric mesenchyme, which is basically the glomerulus all the way up until the distal convoluted tubule. And then the ureteric bud is the collecting duct into the calyx, into the pelvis, into the ureters. Ureteric bud, ureter, so that can help you as well. So the path tie-in here is a pathology state called renal agenesis. And in renal agenesis, the underlying agenesis, no, genesis, generation of or development of. So basically this is no development of one or both of the kidneys. That's renal agenesis. And what happens with renal agenesis, like why it happens, is the ureteric bud does not develop. And remember, like I said, if there's no communication or like not miscommunication, they're not people, but if there's like no communication or like something's wrong with the communication between the ureteric bud and the metanephric mesenchyme, it's not going to develop properly. So at this point, there's no ureteric bud. So it's not even like there's faulty communication. It's just there's no communication. So there's no signals going to the metanephric mesenchyme. So now that kidney just doesn't develop. It's like, nope, all right, yeah, okay, guess we're not doing this today. So renal agenesis can happen in one kidney or it can happen in both kidneys. If it only happens in one kidney, this is something to understand about the kidneys just moving forward, is even if you have like, not even renal agenesis, but if you have like a kidney, like something's wrong with one kidney, the other one can take over. And it's fine. Like it just compensates. It just does everything more. It filters the blood more. It just works more. That's why you can live with one kidney. That's why you can do kidney transplants where you literally donate a kidney to someone, because you can live with one because the other kidney can compensate. I mean, it's not great though, like because over time, like that one kidney, it's doing the job of two kidneys. So it can undergo hypertrophy, hyperfiltration. It can just get damaged. And then eventually you'll go into renal failure. However, if you have renal agenesis of both kidneys, so both ureteric buds did not develop for both kidneys, now you have what's known as Potter sequence can develop. So bilateral renal agenesis can cause Potter sequence. So Potter sequence, this is a very high yield pathology state to know for renal. So this is again, so Potter sequence itself is caused by bilateral renal agenesis. So it's just kind of understanding like what's the underlying basis of this. But renal agenesis does happen, but the actual causes and symptoms that you see of Potter syndrome is due to oligohydramnios. So breaking up that word, oligo means like little to none. Hydramnios is amniotic fluid. And so we're like, okay, why are we talking about amniotic fluid? Like, isn't this kidneys and amniotic fluid like for repro? And so something that's really about to like just be like blow your minds right now. Amniotic fluid is basically fetal urine. That's what amniotic fluid is. And the whole point of having amniotic fluid is one, so the baby or the fetus, the developing fetus is cushioned in mom's uterus. So there's a nice cushion. So they're like floating around in like a nice, comfortable environment. That's the first reason that we have amniotic fluid. The second reason we have amniotic fluid is to allow for lung development. And this is the part that's absolutely wild. So like I said, amniotic fluid is fetal urine. But no lie, the fetus drinks its own amniotic fluid, swear to God, drinks its own amniotic fluid, and then it pees it out again, and it goes through this cycle. But when it's drinking it, why this is important for lung development, you're like, wait a second, you said drink, not breathe. When they drink it, their esophagus isn't totally formed, right? Like the trachea is not totally formed. It kind of allows for that process to like solidify. It helps the lungs develop because it helps the lungs be better at like vasoconstricting. Like if any of that amniotic fluid were to go through the trachea instead of the esophagus, the lungs are going to develop properly and be like, no, this shouldn't be in here. We don't need fluid like in this area. So it just helps them develop properly. So drinking the amniotic fluid is super, super critical for lung development. So they pee out amniotic fluid and then drink it. And this process happens over and over and over again. If you don't have amniotic fluid, one, the lungs are not going to develop properly. So we have lung hypoplasia. So hypoplasia, small development or like no development. They're just not development, but like growth, I guess. So the lungs just aren't going to like grow correctly. And then the other two of the triad that you see with Potters is stuff that you can imagine not having amniotic fluid. So now instead of having a nice cushion in the uterus, the fetus is going to be shoved up against the walls of like mom's uterus. So they're going to have limb deformities, like just literally imagine like a tight squeeze of this fetus in mom's uterus. So limbs are going to get deformed and the facial features are going to get squished. I like call it squished facial features, but the actual term is Potter facies, and it's again all things that you could imagine happening if like the fetus is shoved up against the wall, like shoved up against something getting squished. So there's low set ears, the nose is beaked, so like pushed up against. There's prominent epicanthic folds, downward slanting eyes, again kind of like shoving like the top, like just shoving it down. So this is your triad of Potter sequence. It's caused by oligohydramnios, which happens because there is no kidneys. There's renal agenesis causing no kidney. So we have bilateral renal agenesis, no amniotic fluid or like decreased amniotic fluid. Oligohydramnios causes fetal compression as well as lung hypoplasia. The lungs just cannot develop properly. The next kind of like anatomy tie-in is horseshoe kidney. So, or path tie-in. This was actually asked on my boards. I actually found the exact x-ray that they had on my boards with horseshoe kidney. But basically with horseshoe kidney, how they can test anatomy for this is horseshoe kidney, first of all, is when the bottom portion, so they'll call them like the caudal poles. So the caudal, the lower poles of each kidney fuse together. For whatever reason that happens, it's probably some sort of weird communication between the bud and the metanephric mesenchyme. So these fuse. And remember how I said during, well, I haven't actually said it yet, but during kidney development, this is all happening very low in the body, and then it kind of ascends when it's ready. So if these two portions are fused together and it starts to ascend, it can literally get stuck on the first structure it comes across, which is the inferior mesenteric artery, which is a branch of the abdominal aorta. So my question on boards was, it showed me an x-ray of a horseshoe kidney and then said, what is the structure that it got stuck on? So that is your inferior mesenteric artery. So here's my exact picture that I found that was on boards. So they just showed me this and they were like, all right, what structure is it? And I'm like, what? But here's the horseshoe kidney right here. So the kidney should be here, and they're not. They're here because they got stuck on this guy. And this is the inferior mesenteric artery. This is what basically traps it. And yes, I drew a smiley face yesterday. I drew a smiley face today because I'm just so jazzed about renal, right? We love renal. But anyway, they can show you an abdominal x-ray about this, or they can even show you an abdominal CT, which again, here's your horseshoe kidney. So it looks like a horseshoe. That's where it gets its name. And then kind of the last pathology state we'll talk about with like renal embryo is the patent urachus. So patent, like we've been seeing with like a PFO and like a patent ductus arteriosus, patent means open. So this is saying like after birth, there's something that shouldn't be open is open. So the urachus during development is, you have to remember like when we're developing, we start as like really, really tiny little things and then we develop and we get more complex and whatnot. So during development, we're basically a series of tubes. And this is what I kind of mentioned, like you can go into this type of development more so for second year. I didn't really go into this a lot for because you don't really need to know it yet. And you'll get a lot of embryo when you do some UWorld questions next year. But just to understand this pathology state, when we're developing, are a series of tubes. A lot of the tubes connect random structures to other random structures in the body. One of those random structures that we have is called a urachus. The urachus, during embryogenesis, connects the bladder. So if I get rid of all these other tubes, it connects the bladder to the belly button or the umbilicus. That's just what it does in embryogenesis. Once you're born, it is obliterated and it turns into the median umbilical ligament. Remember I said don't get confused with the umbilical vein turns into the medial umbilical ligament. This is the median umbilical ligament. So don't get confused. So just keep that in mind. Just really keep that in mind because they do really like to ask about the fetal derivatives, what they turn into. So if both are there as options in multiple choice, you're like, oh no. Christina said they were gonna do this. So just remember, median umbilical ligament is what the urachus should turn into after birth. If it does not completely get obliterated and turn into this ligament, it remains patent, or it can remain as a cyst, or it can remain as a diverticulum. And I have pictures showing you this. I should have put my buzzword B here, but classically what you'll see in questions is it's going to be a newborn. So a newborn that shouldn't have a patent urachus anymore. It's a newborn. Now there's urine leaking from the umbilicus. So out of the belly button, there's urine leaking out of the belly button. There's an equivalent to this in the GI system, but I didn't mention it because we're not doing GI. But in kidney stuff, this is a patent urachus. That's the pathology state. So here's kind of the picture. So here's what a patent urachus would look like. So here's a bladder, and then you can see it just the connection is still there. And so you can imagine just urine kind of leaking out after the baby's born. You can have a diverticulum. So if you see the word diverticulum, this usually means like an abnormal outpouching. So it's not quite connected, but it is like the bladder should only look like this, but we have this abnormal outpouch. That's a diverticulum. So this is a urachal diverticulum. And then over here, this would be a urachal cyst. So the bladder's fine, but we had incomplete degeneration of the urachus. So a cyst can form, which is what happens. And they're not going to present, these two are obviously not going to present with belly button urine basically like leaking out. but they will present with their own pathology states. They can get infected. A lot of the times these things like diverticulum and cysts get infected. As soon as you think of diverticulum, think about diverticulitis. You probably know people that have diverticulitis. This is like a GI thing, but that's all it is. It's a diverticulum that now gets infected because it's really easy to get infected. And same thing with cysts, really easy to get infected. So they'll probably present with a little bit different symptoms, but if you see the belly button leaking out of, oh my God, I keep saying that, urine leaking out of the belly button, that's a patent urachus. That's that pathology state. Okay, we're almost there. We made it. All right, so now I just have I have 5 questions, but the last one is for one of the congenital cardiac defects. So we're going to do 4 really quick questions. So you guys can pause this and do them, but I'm going to keep going. So this is where you guys would all be sending me the answers, and I'd be like, yay, you guys all got them right. I'm like, yay, awesome. So this is basically saying there's a mass at the aortopulmonary window, patient with hoarseness. You're like, left recurrent laryngeal, aortopulmonary window, boom. And I like this question too because it's like, which of the following nerves is most likely compressed? I like actually that they put vagus as a choice, but remember, the vagus nerve getting compressed isn't hoarseness. The vagus nerve getting compressed would do all sorts of stuff. There would be the vagus nerve innervates like so many things in the body, so there would be a lot more symptoms. Hoarseness only would be your left recurrent laryngeal, even though technically, yes, it is a branch of the vagus nerve. Okay. Next question, so you guys can pause this. So this answer is going to be A. So this is basically Potter sequence, basically. So failure to urinate during embryonic or fetal life can cause respiratory difficulties postnatally. Which of the following relationships best describes this? So this is also where I say I'm so happy that nobody got, unless you did get got right now on the recording. That's all right. Look, don't get got. That's why I like to put questions on here and have you guys do questions after session so you don't get got in the future on the exams. So I'm glad when we did this during the live session, nobody got and was like, oh, renal agenesis, that's definitely it, and picked it. Renal agenesis is not linked to surfactant in any way, shape, or form. They just have nothing to do with each other. Renal agenesis leads to oligohydramnios, and then oligohydramnios is linked with those hypoplastic lungs. That's your lungs. That's your Potter sequence, which is what it says here. Next question. So you can pause it, but for this one, this is basically saying someone had a head-on collision, blunt force trauma to the sternum. So what part of the heart is likely to be injured? Well, remember, the right ventricle is directly behind the sternum. So if you directly hit the sternum, that's right ventricular. You would injure the right ventricle. Good, so just kind of like knowing how the heart is oriented in the chest. And then the last question, there is one more question, but we're not going to do it because we didn't do congenital stuff. So fusion of the caudal portions of the kidneys, horseshoe kidney, that's the answer. Again, they could have made this harder. They asked like which artery do they get stuck on? What's the thoracic level of the artery or thoracic or lumbar level of the artery that it gets stuck on? Like they can switch this up in so many directions. But yeah, so this is horseshoe kidney. And that's how they word it. Fusion of the caudal portions during embryonic development, which is what they kind of mention here. They say the ascent. It is really like an air quote. It is like the ascent because it's really just moving like a little bit, but it still can get stuck on the IMA. All right. So that's all I'm going to do. I'm going to stop sharing. But basically, thank you guys for bearing with me. It's super long, I know. Good luck with everything, and just let me know, or let like your PBL rep know too. Like if you guys want another session with anything, just like he can organize it with me, and we can set these up more frequently if you guys want. But okay, have a good day, everyone.